All right, well, good morning. Thank you for joining us. And I want to welcome you to the 37th annual and first ever all virtual annual meeting of the Northeastern Society of Plastic Surgeons. It's my distinct pleasure to welcome all members as well as future members of our society to this meeting. Although this clearly has been an unconventional year to say the least, I'm so grateful we're able to come together and celebrate the work of so many accomplished and young surgeons and students. The NESPS was faced with the possibility of canceling this meeting altogether. But after receiving over 400 very impressive abstract submissions, myself, Program Chair Suhail Kanchwala, the Program Committee, and the Northeastern Society Board of Directors determined we must find a platform for our future members to present and to continue our annual tradition. I'm so thrilled we're able to host the meeting for you this weekend. Our Program Chair, Dr. Suhail Kanchwala, who I'll turn this over to shortly, and his committee had the unenviable task of reviewing over 400 submitted abstracts. And this was a record for the society and almost double from most previous years. I personally read them all, and I could say for sure they were quite impressive. We wish we could have extended the day to allow more presentations, but given the platform and the limited time constraints, opportunities were extremely limited, understandably. We hope you'll appreciate the live presentations today and tomorrow, but please, I ask that at some point you take some time to also review the online portion of the program. On the virtual program portal, you could view the 52 additional virtual podium presentations that cannot be included in today's live program due to time constraints, and please rate them using our STAR scoring system. We consider these virtual only papers part of our formal program as well, despite our inability to include them in the formal program today and tomorrow. Before I pass the reins over to Dr. Kanchwala, I want to thank Suhail and his committee for all their hard work and for keeping an open mind as we navigated this new territory. I also want to personally thank our moderators who agreed to participate and share their expertise with us this weekend. In addition, the staff of our management company, PRRI, should be commended for their incredibly hard work and the massive efforts it took, not only to put this program together for us, but to do it on such short notice. On behalf of myself and the Northeastern Society Board of Directors, thank you, and thanks to all the presenters today. I hold out hope that we could look forward to a more normal annual in 2021, and I hope to see all of you there with me in Philadelphia next fall. And finally, please don't forget to look out for information about our spring workshop in March, which we still hold out hopes to host in person. However, a virtual version is on the table depending on the circumstances, obviously. Either way, all of our presenters who are scheduled for that workshop have agreed to participate once again. So the day should be an outstanding educational opportunity for all, and you'll be receiving more information about that after this meeting's over. And for now, I'd like to introduce our program chair, Dr. Suhail Kanchwala. Thank you.
Well, thank you very much, Brian. It is my pleasure and honor to welcome you all as well to our virtual meeting this year. As we enter this crazy fall, we are reminded that this time is typically a time to reconvene with our colleagues and our mentors and medical students and fellows throughout our region as we enter the fall season of meetings, and it's something that I miss very, very much. And I am so glad that we were able to host this virtually, not only because of the quality of the abstracts, but hopefully the quality of the discussion. I remember last year's meeting very vividly as I met new friends for the first time. And for example, I met David Otterburn and I learned how he was using implant reconstruction without drains. I've tried it in a couple of cases. There's so many things that we get in our connections to our colleagues that I hope doesn't get missed in this format. I also want to thank our moderators. We are blessed in this region to have moderators and leaders in every aspect of plastic surgery. We've attempted to gather them all today and tomorrow, and I think you're hopefully going to enjoy a lively discussion with all of our moderators and presenters. Lastly, I want to thank our sponsors. In the best of times, our sponsors allow meetings like this to happen. And even in our times of great stress, such as this period, our sponsors have been vital to our ability to let meetings like this continue. And so I hope that you take a few minutes during the meeting and even slightly after the meeting to visit the virtual marketplace. This is a really cool idea. PRRI has helped put this together. Heather, Stan, and Olivia have really worked hard to be able to get a virtual marketplace where you can actually interact with our sponsors. We all use their products. We need their products to help our patients. And I think it's really critical that we show how much we value their support of our society. A few housekeeping items before we start. Number one, Even though we can't be all together in the same room, we certainly can interact, and we hope you use the question and answer feature of Zoom to interact with the presenters as they are giving their presentations. The way this is going to work is after we hear all of the presentations, there's going to be a question and answer session. And if you log your comments and questions in the question and answer session, the moderators will actually select from those questions and answers, or rather questions, to be able to pose to the presenters who will be answering these questions live. One of the things that in a normal meeting we don't get the opportunity to do is ask a lot of questions. You may only have one or two people actually present their questions on the on the microphone. Here we don't have that limitation, so please be free to use the question and answer session. I want to remind all the panelists and the presenters to please mute their speakers when they're not speaking so that we avoid any feedback issues. Also, presenters should use their name and their abstract number in their Zoom name so it's easy for the moderators to call on them. And lastly, I want to thank Brian for all his years of hard work on behalf of the society. And if there's any one president who deserves to be president twice, it's Brian. With that, I think I'd like to start off by starting the residence competition, something that's always been near and dear to my heart every year.
Great. Thank you, Suhail, so much. Really appreciate that introduction. So for the resident competition, I believe it's going to start momentarily. And the first presentation for the residence competition will be regional pain blocks and perioperative pain control in patients undergoing breast implant removal with capsulectomy.
Hello, my name is Jacob Katz-Nelson, and I'll be talking about regional pain blocks and perioperative pain control in patients undergoing breast implant removal with capsulectomy. I have no disclosures. The background of the study is that increasingly more patients are undergoing breast implant removal with over 33,000 performed in 2019. It's about a 50% increase from 2018, according to the ASPS statistics released every year. Demand has been steadily increasing due to patient safety concerns or symptoms they ascribe to their implants, with many patients requesting an in-block capsulectomy. Pain control can be very difficult on these patients due to previous scar tissue around the implant, the potential for extensive dissection in those patients who are requesting an in-block capsulectomy, and variable innervation of the underlying breast in patients that have had multiple previous implant placements or prior breast surgery. Previous studies regarding ultrasound-guided regional pain blocks have shown that they can serve as a significant adjunct to perioperative pain control in breast surgery patients, but evidence to support a specific block is limited and has not been assessed in this particular population. Our objective was to assess the efficacy of different regional pain blocks for postoperative pain control in our patients who undergo implant removal with capsulectomy. This was a retrospective single institution review. We included all patients from 2018 to 2020 that had an implant removal and capsulectomy at our ambulatory surgical center. These patients received a combination of 4 different ultrasound-guided regional blocks before surgery: the serratus anterior, the erector spinae, the pectoral 1, or the pectointercostal fascial plane block. Seen here in this figure is the erector spinae block, where about 10 cc's of local is injected between the erector spinae, just deep to erector spinae, but superficial to the transversus process. This is to block the nerves in the T2 to T9 distribution. It's usually combined with an anterior chest wall block, most often the pectoral 1 block between pec major and pec minor, which blocks the medial and lateral pectoral nerves. We compared as our outcomes intraoperative, postoperative opioid requirements, and patient-reported pain on postoperative day 1. Here are the results of our study. We had 352 patients. The vast majority of them underwent an ES plus PEX1 regional block, which is preferred by our anesthesiologists. About 89% had that block versus about 7.4% that had a serratus block, or 3.7% that had a ES-PIFP block. About 5.4% of patients required opioids intraoperatively, and about 27.8% required opioids postoperatively in the recovery unit. On post-op day 1 follow-up, about 11.4% of patients reported no pain, which is 0 on the visual analog scale. 21.1% reported minimal pain, which is a 1 to 2 on the visual analog scale, and 36.8% reported mild pain, which is a 3 to 5 on the analog scale commonly used. The combination of ESPEX1 was associated with less intraoperative and postoperative opioid requirements compared to the other two block techniques. As shown in the study, this was statistically significant for postoperative narcotic requirements, did not reach statistical significance for intraoperative requirements, largely because there weren't that many patients that required opioids intraoperatively. Additionally, ESPEX1 was associated with mild pain on post-op day 1 compared to the two other regional block techniques as seen in these figures. About 40.2% of patients reported mild pain compared to the serratus block where there was 12.5% of patients, and ESP-FIP block as associated with the most significant post-op day 1 pain compared to the other two techniques. So the conclusion is that ultrasound-guided regional pain blocks can certainly serve as an effective pain control regimen for patients who undergo breast implant removal and capsulectomy in the ambulatory setting, resulting in overall low perioperative opioid requirements and good patient-reported pain scores in the immediate postoperative period. The technique combining rectus spinae block with pectoral 1 block appears to be superior to the serratus plane or the pectointercostal fascial plane block in our study. There are, of course, limitations to this study. We don't have a control group. All these patients had regional anesthesia of some sort performed. The choice of incision depended on the procedure. Oftentimes, this was combined with either an implant removal and a mastectomy in patients that were candidates, and this was surgeon dependent. The extent of the capsulectomy also varied by patient, and there's, of course, a subjectivity bias. These patients were reporting pain on post-op day 1, and additionally, there was short-term follow-up, as in we do not have a discrete sort of data available for patient pain control after post-op day 1. With that, I will open the floor to any questions regarding the study. Thank you for your attention.
Thank you so much. Our next paper will be smooth versus textured implants in post-mastectomy reconstruction. Evaluation patient-reported outcomes and clinical
smooth versus textured breast implants and post-mastectomy breast reconstruction, and evaluation of patient-reported outcomes and clinical complications. We have no disclosures. Improved understanding of ALCL pathogenesis has resulted in an increase in patient inquiry into the exchange of textured to smooth breast implants. Studies evaluating surgical outcomes of smooth and textured breast implants have yielded mixed results. Furthermore, to date, there are no studies comparing patient-reported outcomes of smooth and textured breast reconstruction. Our group has recently published a paper in the Annals of Surgery demonstrating that the risk of ALCL is much higher than previously thought. This makes it even more important that plastic surgeons are able to appropriately counsel patients seeking information on the risks and benefits of exchanging textured to smooth breast implants. The purpose of this study was to compare patient-reported outcomes and complication profiles in patients undergoing breast reconstruction using textured or smooth breast implants. Our hypothesis was that patients will report similar outcomes in both smooth and textured implant-based breast reconstruction, and that the two groups will also have similar complication profiles. This study was conducted by retrospectively analyzing a prospectively maintained database, which yielded 1,077 patients from January 2009 to July 2017 at Memorial Sloan Kettering. We assessed demographics, breast Q scores, and complications. Regarding demographics, the results were largely similar. We had 785 smooth breast implant reconstructions and 292 textured implant breast reconstructions. The only differences in the groups were that there was a slight difference, but statistically significant difference in BMI, and similarly for radiation. Regarding breast Q satisfaction scores, there was no differences noted at 3 months, 6 months, 1 year, and 2 years between the smooth and textured breast implant groups. Similarly, the breast Q well-being scores were also similar between the two groups at the aforementioned time points, with the only difference occurring in sexual well-being at 1 year. Regarding postoperative complications, there were very few differences noted between the smooth and textured breast implant reconstruction groups. However, it should be noted that there was a significant increase in rippling noted in the smooth implant group, and a significant increase in cellulitis at 9.6% in the textured implant group compared to only 5.5% in the smooth implant group. In summary, our results demonstrate similar patient-reported outcomes between patients with smooth and textured implant-based breast reconstruction. We noted that there were minimal differences in complications, with only being more rippling in smooth implants and more cellulitis with textured implants. One of the big strengths of this study is that it is very timely, as more patients are starting to inquire about the risks and benefits and how they'll feel if they go from textured implants to smooth implants. We also employ a very large sample size at 1,077 patients. However, there are also limitations. For example, a greater proportion of the radiated group, of the textured group, was radiated compared to the smooth group. We did, however, evaluate outcomes of the non-radiated patients between the two breast implant types and found that the outcomes were similar. There was also a variable breast Q response rate, which could have been possibly linked to a healthy responder bias. And regarding the complications, we relied on accurate measurements as per documentation in the electronic medical record. So there is a chance that there could be a possible recorder bias. In conclusion, we describe here that surface texturing may not directly impact patient-reported outcomes in post-mastectomy breast reconstruction. This data is valuable when counseling patients seeking information regarding exchange from textured to smooth breast implants. Thank you.
Thank you very much. Our next paper will be Progressive Multisutural Craniosynostosis in Syndromic, Non-Syndromic Patients, Identification of Patterns and Risk Factors. I remind everyone that you could ask questions along the way.
Hi, good morning. Thank you for the opportunity to present this research. Craniosynostosis affects up to 1 in 1,700 infants worldwide. Progressive multisutural craniosynostosis, which is the subject of this research, is the fusion of an initially patent suture after surgical intervention to treat craniosynostosis. This is in contrast to progressive postnatal craniosynostosis, in which patients with a normal head shape and open sutures at birth go on to develop multisutural craniosynostosis postnatally. This is also in contrast to restenosis, or the bony reformation at the site of a prior strip craniectomy. Prior reports of PMSC have identified potential risk factors. Marucci et al. Reported 7 patients who presented with a vertex bulge after strip craniectomy for scapucephaly. 5 out of 7 were found to have developed bicoronal fusion, and FGFR mutation were identified in 2. Sedas et al. Found a statistically significantly younger age at first operation compared to patients who did not develop PMSC, and Vaca et al. Examined non-syndromic patients exclusively and found endoscopic suturectomy with barrel staving to be a significantly associated factor with PMSC, and hypothesized that wide surgical undermining of the calvaria from the dura and or transection of previously patent sutures with barrel staving could be a potentiating factor in the development of fusion of these previously unaffected sutures. The purpose of this study is to identify further patterns and risk factors in both syndromic and non-syndromic patients who develop progressive multisutural craniosynostosis. A retrospective review was performed of patients who were diagnosed with craniosynostosis, underwent surgical treatment, and had at least 2-year follow-up. Genetic testing was performed on patients with the risk factors listed below. On all patients, we collected the following data points: the presence of a syndrome, the initial fused suture, the modality of treatment, and the age of primary surgery. In the PMSC cohort, we additionally looked at the second fused suture, the time to development of PMSC, the modality of treatment, and age of treatment. 76 patients met criteria for inclusion in the study, 8 of whom have PMSC. The mean time to development of PMSC was 23.3 months. 5 out of 8 were detected with a progressively abnormal head shape, 2 of whom also had worsening developmental delay. 3 out of 8 were identified on routine postoperative CT. 73.5% of patients in the control group presented with single suture craniosynostosis initially, versus greater than 60% of patients with PMSC presented with 2 or more fused sutures. Looking at the individual sutures, our univariate analysis revealed bicoronal fusion as a significant risk factor for the development of PMSC. Additionally, the presence of a syndrome was found to be significantly associated with PMSC. Although the patients in the PMSC subgroup underwent surgery a mean of 3 months before the control group, this did not reach statistical significance in our analysis. The authors then performed a non-syndromic subgroup analysis and found that even within the non-syndromic subgroup, bicoronal craniosynostosis was found to be significantly associated with the development of PMSC. Although 40% of patients in the PMSC subgroup underwent endoscopic strip craniectomy compared to 22% in the control group, this did not reach significance. The authors then performed a syndromic subgroup analysis, which only comprised of 8 syndromic patients, 3 with PMSC and 5 without. There were no overarching patterns when comparing the control group and the PMSC subgroups. The authors additionally examined the secondary suture fusions in the non-syndromic and the syndromic patients with PMSC, and again found no overarching patterns between the two. 6 of the 8 patients underwent a second operation for treatment of their PMSC versus 2 who were lost to follow-up. The average age of secondary surgery was 30.3 months. 5 underwent calvarial vault remodeling and 1 underwent distraction. In conclusion, the presence of a syndrome was found to be significantly associated with PMSC. Bicoronal fusion was also found to be a risk factor even within the non-syndromic cohort, although it's important to acknowledge that these patients may have syndromes or mutations that are yet to be identified. The age at the first operation, the type of operation, trended towards younger age and endoscopic strip surgery, but this did not reach significance in our analysis. We were limited by the small sample size given the rarity of this condition, and ideally would want to examine these factors in future studies with greater numbers. Thank you.
Thank you very much. The next paper will be Turning Back the Clock with Facelift Surgery, Artificial Intelligent Recognition of Age Reduction and Patient Satisfaction Quantitates Value of Specific Techniques.
Thank you for the opportunity to present today. We have no financial disclosures. Facelifting is one of the most powerful tools in the plastic surgeon's armamentarium to rejuvenate the aging face. These patients always want to look and feel younger. Unfortunately, as surgeons, it's difficult to objectively evaluate these results. But advances in machine learning and convolutional neural network allow for machine quantitative evaluation of our postoperative results. These convolutional neural networks are trained on millions of normative images, and they're able to produce a variety of learned outputs, including gender, age, and even what emotion the patient might be feeling in the photograph. We use these to analyze 50 consecutive facelift patients. Their pre- and postoperative frontal and lateral photographs were fed into 4 different neural networks. We then used their pre- and postoperative perceived and estimated ages in order to generate an estimated age reduction after facelift. All patients also completed a FaceQ questionnaire in order to correlate their satisfaction with their perceived age reduction. We first tested the neural network accuracy against their preoperative age. If 100 is perfectly accurate, you can see here that all 4 neural networks do fairly well in determining the preoperative age. They then generate this sort of output. This facelift patient is preoperatively 62. The patient herself appraises her post-op age as 58 for a reduced age of 4 years. The neural network estimates her post-op age as 60 for a reduced age of 2 years. Overall, patients seem to appraise themselves as being younger than the neural networks did. The mean age reduction on self-appraisal was 6.7 years, and the mean neural network estimated loss of age was 4 years. When you correlate the overall satisfaction on FaceQ with the estimated age reduction, there's a positive correlation showing that patients are more satisfied when their estimated age reduction is greater. When you break it down further, there's also a positive correlation with the quality of life, which includes social function and psychological well-being, and process of care, which includes this overall satisfaction with outcome and their satisfaction with the decision to undergo surgery. Overall, these neural networks are able to objectively assess the success of these facelifts in reducing the perceived age of the patients. Greater age reduction is then correlated with a greater patient satisfaction. We then broke it down further and determined which facelift techniques brought the greatest age reduction. We looked at skin-only facelift, SMAS plication, and mastectomy. In this chart here, you can see that skin-only facelifts had the least estimated age reduction, and was significantly lower than both the SMAS plication and mastectomy groups. We also looked at fat grafting versus no fat grafting. And you can see here there's a significantly greater age reduction when fat grafting is applied to the patient. These results suggest that treating the SMAS improves age reduction, and fat grafting also improves age reduction. In conclusion, these convolutional neural networks are able to show that facelift successfully reduces the perceived age of patients. Overall, these neural networks also allow for objective evaluation of results and can allow surgeons to quantitatively assess their outcomes for a wide variety of aesthetic procedures. Thank you.
Thank you. For the final paper of this portion of the session will be Prospective Real-World Assessment of the Abdominal Hernia, Q, Patient Burden, Reliability, and Longitudinal Assessment of Quality of Life in Hernia.
My name is Vin Patel, and I'm here to present on behalf of the Penn Plastic Surgery Group. Today, I'll be talking about our experience with prospective testing of the abdominal hernia Q, or the HQ as we like to call it. So ventral hernia is a growing problem, and we've seen an increase in the number of ventral hernia-related discharges, repairs, and subsequently costs associated with ventral hernia. Historically, traditional outcome measures have been used to assess the success of ventral hernia repair, things like reoperation, readmission, and hernia recurrence. However, these outcomes fail to truly capture the disease burden associated with ventral hernia, including negative impacts on body image, chronic pain, and persistent functional limitation. There may be a way to more accurately quantify patient quality of life by putting patient perspective at the forefront. In 2018, we published on the detailed development of the AHQ, starting with rigorous qualitative work with actual ventral hernia patients, followed by field testing and ultimately psychometric validation. In this, we posited that the AHQ was a superior patient-reported outcome measure to measure hernia-related quality of life because it was disease-specific, it had high content validity, it was psychometrically validated, and it provided pre- and post-operative forms which allowed for more granular quality of life information. And here's an example of the 8-question preoperative and 16-question postoperative instruments. With development of the actual survey complete, we then turned to prospective testing of the AHQ's clinical usability and longitudinal validity in capturing quality of life information after ventral hernia repair. Patient burden is tied into clinical usability as it impacts both response rates and implementation in a clinical setting. To measure it, we manually timed over 200 patients completing both the pre- and post-operative instruments and found low rates of user burn overall, with completion times of 67 seconds and 161 seconds for the pre- and post-operative instruments respectively. The elderly did take longer to complete both instruments, and iPad administration reduced burden overall. We then set out to test the stability of the AHQ in measuring hernia-related quality of life information. We did this through a test-retest methodology where patients who completed the AHQ were re-administered the same instrument over a week later. When correlating results from the test-retest, we found that the AHQ was highly reliable in capturing hernia-related quality of life information, with Pearson reliability coefficients of approximately 0.9 for both instruments, indicating the AHQ could be used on an individual basis to measure quality of life information. We then set out to test the accuracy of the AHQ in capturing quality of life data longitudinally after surgery. We did this by comparing it to other available quality of life metrics, including the Hercules and SF-12. We found that the AHQ was significantly correlated with the Hercules at all time points in the postoperative period and all time points of the SF-12 mental score. AHQ is also significantly correlated to 4 out of 5 time points of the SF-12 physical score, with the exception of the after 13.5 months post-op, which had low response rates for both surveys. When we graph the 3 metrics against each other, we really see the value of a disease-specific instrument. The SF-12 has modest gains after ventral hernia repair compared to the AHQ and the Hercules, suggesting it isn't truly capturing all the aspects of hernia-related quality of life. Furthermore, we get insight into the healing process after hernia repair with immediate increases in quality of life in both the AHQ and the Hercules that continue for up to a year postoperatively. Effect size has been used as a proxy for clinical significance and sensitivity when comparing different patient-reported outcome measures. The reason for this is that clinicians would like a measure that responds appropriately to both changes in quality of life and to intervention. Here we see the AHQ responds with the highest effect size in every postoperative period when compared to the Hercules and the SF12. Additionally, we once again see the importance of a disease-specific measure, with the SF12 consistently reporting the poorest effect sizes amongst the three measures. With this, we have completed the multi-year cycle of problem development, starting with qualitative work to extensive psychometric validation, and now prospective testing of the actual usability of the AHQ in clinical practice. In summary, we believe the AHQ is very easy to implement as measured by low user burden. It is highly stable as measured in a test-retest methodology, responds appropriately to intervention and changes in quality of life, and it has the highest sensitivity to change amongst any of the available quality of life measures for hernia repair. In conclusion, the AHQ is a novel, stakeholder-informed, patient-reported outcome measure that accurately measures quality of life information in hernia patients. By now demonstrating its clinical usability and longitudinal validity, we have set the stage for wide-scale dissemination and use of the AHQ as the universal patient-reported outcome measure in ventral hernia repair.
Well, fantastic. That was a wonderful session of some really great research in the full gamut of plastic surgery. I want to start the question and answer session off by addressing some of the question and answers that were actually turned in during the session. For the facelift paper, this is a question from Manas Nigam. A big criticism of machine learning is that there's a bias baked into the actual neural network itself. What data sets were used to derive these neural networks themselves? Thousands of diverse faces, age ranges, or age of BMIs? And what was then, and was that then used to look at the 50 faces?
Hi, thanks for the question. Yeah, so these neural networks have been developed by third parties already, like Amazon, IBM, Face++. So their data set is more on the order of millions of images, and they do use very diverse faces. In the past, in the literature about these convolutional neural networks, they tend to do better in recognizing Caucasian faces, but we did not see any distinction in that in our patient group. And we did use both Caucasian patients and non-Caucasian patients.
Fantastic. The next question is for Dr. Nelson. I loved your paper. Dr. Bucky asks, did the study identify a correlation between patient satisfaction and individual surgeon as an independent variable?
Good question. We looked at the aggregate number of surgeons together. We did not look at individual surgeons. So no, essentially all surgeons who were involved in the cohort performed both textured and smooth implant procedures. Over time, there were differences within the practice patterns, being earlier in the study period, textured implants were used more often. Later in the study period, there was a transition towards smooth, but we did not look at individual surgeon satisfaction scores.
How do you account for the difference in cellulitis rate? That's kind of odd. Was there a difference in ADM usage between these two groups?
There was not a difference in ADM usage. In terms of the cellulitis rate difference, it's hard to say exactly. It could be the microtexturing on the devices having had to do with the biofilm that could be present. You know, this is an observational study, so we didn't look specifically at those more sort of microscopic components. I think there's also as I mentioned, because of the difference in utilization, there's a time bias towards longer exposure in the textured implant group. So it is possible that because there was a longer period of time of exposure simply to a device, there could be higher rates of cellulitis as a result, although the multivariate regression analysis didn't really play that out.
Fantastic. Next question is for paper number 1. In your analysis, and it's very prescient and important work because we're all trying to improve pain control after our surgeries, particularly in breast surgery. But there was a significant difference in the number of patients who had erector spinae blocks and then other blocks. Pretty much 90+% of patients had an erector spinae block, which is not a common block. Is that block done prior to the induction of anesthesia, since it's on the back? And would you think it would be better to compare erector spinae block to the more commonly done PEX block alone rather than in conjunction?
I believe he's muted.
Okay, well, we're gonna move on, and we'll hopefully get that answer. Oh, yeah, hopefully we'll get that answer in the question and answer session. Another question for the convolutional neural networks paper. So I found that very, very interesting paper, even though I have absolutely no interest in facelift surgery. The cool thing about that is I think that there probably could be lots of different applications to this modality in pediatric surgery, throughout reconstructive surgery. Have these machine learning algorithms been used to evaluate any other outcomes from, for example, facial reanimation surgery or cleft lip and palate repair?
No, not that I know of. There's a lot of development in convolutional neural networks for radiologic development. So they're getting very, very good at reading CT scans, X-rays. In terms of aesthetic or like post-surgical outcomes, I believe we're one of the first to use it to look at that. And in terms of facial reanimation, these neural networks aren't as good at analyzing video currently. So they're much better at analyzing static images. So it'd be more difficult for facial reanimation.
Fantastic. For paper number 5 with the abdominal hernia queue, I think again, patient-reported outcomes is a huge part of plastic surgical research, and really it's the thing that we should care about the absolute most in every surgery that we do. When you're looking at developing a new instrument such as the abdominal hernia queue, do you have a specific time point where it'd be most relevant to, if you could only give this at one time point, when is the best time point to give this to predict the outcome that you desire?
Yeah, so we're looking into this currently. If we're turning it into a decision-making tool and looking at preoperative quality of life information to help decide which patients best will benefit from surgery. And at the time, I mean, with what we have, I think the points that we have are really preoperative and then postoperative within 1.5 months. And then 6 months, we saw a big boost in that quality of life. So it seems that after hernia repair, the big time points are within that initial immediate post-op period, and then 6 months after, after the acute healing process is over.
Fantastic. And then I think for the last question for this first group of papers is for paper number 1. Were there any implant removals done under urgent or emergent circumstances, and did that affect the regional block choice?
I believe for paper number 1, we had somebody who was going to answer the questions. Is that person able to unmute themselves, please?
All right, well, let's move on to the second part of the residence competition. Thank you so much for all the presenters and the panelists. The first paper of this session, is it worth the risk? Contralateral prophylactic mastectomy with immediate bilateral breast reconstruction.
Hello, everyone. I'm presenting, is it worth the risk? Contralateral prophylactic mastectomy with immediate bilateral breast reconstruction. I have no disclosures to make. So an increasing number of women are choosing to undergo contralateral prophylactic mastectomy with immediate bilateral reconstruction. Studies have identified fear of recurrence as primary motivation for many of these patients. Others appreciate that there's an aesthetic advantage in choosing a bilateral reconstruction for symmetry purposes. Operating on the contralateral non-cancer side is obviously not without its own set of risks, as it's an extrasurgical site and it's subject to those associated complications. The objective of the study was to compare complication rates between the cancerous and the contralateral prophylactic breasts in mastectomy with immediate breast reconstruction. So we conducted a retrospective review of these patients between January 2008 and 2019 at Columbia University Medical Center. 3 surgeons were involved in the study. We collected all of the data and compared outcomes between the cancerous and the non-cancerous breasts. 160 patients met our inclusion criteria. 47 of them had complications. Complications noted were wound dehiscence, hematomas, cellulitis, seroma, capsular contracture, surgical site infections, and skin necrosis. Of note, patients with complications were more likely to have hypertension, diabetes, radiation, neoadjuvant chemo and adjuvant therapy than those who did not have complications. The rest of the demographic data was not significantly different between the two groups. Also of note, the vast majority of our patients, about 94% of them, underwent implant-based reconstruction. So about 29% of our patients had complications, about 20% to the cancer side only, 5% to the non-cancer side only, and then about 4.4% had bilateral complications. So what we found was that there were significantly more complications to the cancer side than the non-cancer side, but no difference in major versus minor complications. Looking at a breakdown of the complications in the cancerous versus the prophylactic breast. So the cancerous breast is in blue and then prophylactic is in orange. The most common complication overall was skin necrosis. The most common complications for the cancerous breast was wound dehiscence and skin necrosis, and for the non-cancerous breast, capsular contracture and skin necrosis. But of note, none of these p-values were significant. There was no real difference between the two groups when we stratified by complication like this. We decided to take a greater look at radiation, as we know it's associated with complications, and also we saw in our earlier slide that in our sample it was also significantly associated with complications. So we took another look at this, and again, unsurprisingly, we found that having a history of pre- or post-surgical radiation to the affected side did increase the likelihood of complications to that side significantly. So we decided to now exclude these irradiated patients from our sample. Now we have 134 patients meeting our inclusion criteria. About 24% had complications, and now there's no statistically significant difference in complication rates between the cancerous and the prophylactic breasts. So contralateral prophylactic mastectomy with immediate bilateral reconstruction is not without added risk when compared to a unilateral procedure. Others have indicated that the cancerous and non-cancerous breasts have similar complication risk profiles in the setting of bilateral mastectomy with reconstruction. Our study indicates that the incidence of complications to the non-cancerous breast is significantly less than that to the cancerous breast. When we controlled for the effects of radiation, there was no difference in incidence of complications between the two groups. Additionally, when we stratified by specific complication, we don't see a significant difference either. So this information helps add to the existing literature, and it can be used to help counsel patients with unilateral breast cancer on their treatment options and their associated risks. In the future, we'd like to do a meta-analysis of the data available on this topic, and larger prospective cohort studies would also be helpful. Thank you.
The next paper in this session is Predictors of Detransitioning After Gender Confirmation Surgery, a secondary analysis of the United States Transgender Survey.
Good evening, and thank you for the opportunity to present our work at this virtual conference. So anyone who has an interest in providing gender confirmation surgery is familiar with the question or some iteration of what if your patient regrets it? What if the patient wants to return to their sex assigned at birth? And unsurprisingly, there is a dissonance between the reports from conventional news outlets and those from the scientific community, which overwhelmingly report low rates of both regret and detransitioning. So in 2015, the National Center for Transgender Equality conducted the United States Transgender Survey, and this comprised almost 28,000 individuals and covered a number of different aspects of life with the idea of representing the transgender and the gender nonconforming experience in the United States. One of the sections that this survey covered was the topic of detransitioning. So respondents were asked whether or not they had ever detransitioned, and this could be either temporarily or permanently. And in this study, you can see 8% of respondents had indicated that they had at some point detransitioned. And when listening to reasons for detransitioning, you can see that the overwhelming majority of the reasons are due to either a poor social support system or pressure from other social relationships, with the idea of misdiagnosis or mistaken identity being a very uncommon response for why this event had occurred. So the purpose of our study is to provide a secondary analysis of the USTS data in order to determine the characteristics of individuals who have detransitioned specifically after having undergone gender confirmation surgery. So respondents were asked whether they had undergone any of a number of gender confirmation procedures based on whether they were assigned male at birth or assigned female at birth. And having indicated yes to any of these, put them in the surgery group, and they were included as participants in the study, with the exception of those who had only indicated having undergone hair removal, silicone injections, or voice therapy, because they're not standard surgical components of a transition. So if they had undergone surgery, they were then grouped into one of two groups based on their answer to this question: have you ever detransitioned? Yes, I've detransitioned. That's the positive group, and then never having detransitioned for those who had answered no. The variables that we had looked at were demographic variables, as well as variables that explored gender identity, experiences with gender identity, and the social support system and psychological well-being. So you can see from the descriptive statistics that of the about 8,000 participants who had undergone a surgical transition, about 700 had indicated having detransitioned at some point. Again, not specifying whether this had happened before or after the surgery, or whether this is temporary or permanent, just having ever had a detransition event. And then 7,400 indicated having never detransitioned. You can see from the descriptive statistics here that there's a higher rate of detransitioning generally in patients who are undergoing male to female transition, and that the highest rates were in the other group of surgical procedures, indicating that these patients may not have actually undergone a conventional surgical transition. In our multivariate logistic regression, you can see that there was indeed an association between having been assigned male at birth and having detransitioned, as well as an association between increasing age and detransitioning, as you might expect from simply having lived more years. Interestingly, there was no association between race, location of residence, and income when it comes to detransitioning. When looking at variables of identity and social support system, two of the strongest correlations that we had seen were between living full-time in a gender congruent with your identity, meaning that you are openly transgender, and this is associated with low rates of detransitioning, as well as a non-binary status, which had high association with having detransitioned. With regards to social support, those who were single, divorced, widowed, or separated had higher rates of detransitioning compared to those who were married, and those who had unsupportive families or no family at all had higher rates of detransitioning than those who were neutral, which had higher rates than those who were had supportive families. The Kessler scale is a tool used in the psychological literature, and it assigns a score for psychosocial distress. And for every 1 point increase in the psychosocial distress score, there was a 5% increase in the likelihood of detransitioning. It's not uncommon for patients who are gender nonconforming or transgender to have adverse experiences in a number of walks of life, and those who had poor experiences with housing, those who reported domestic abuse, and those who had adverse experiences in the workplace had higher rates of detransitioning compared to those who didn't have these experiences. So in conclusion, detransitioning is a rare occurrence following gender confirmation surgery, and based on the findings in our study, it appears that it's associated mostly with a lack of support in social circles, the presence of psychosocial distress, and the negative experiences with expression of gender identity. So we believe from our findings that it's of utmost importance that patients who are undergoing a surgical transition have a strong support system and social support in order to prevent this event from occurring. Thank you.
The next paper in the series has the increase of women in surgical training programs led to a concomitant increase in female leadership positions, a 10-year analysis.
Hi everyone, my name is Christine Yin, and I am the PGY5 at the Nassau University Medical Center, Stony Brook University Integrated Plastic Surgery Program. My project is titled, Has the Increase of Women in Surgical Training Programs Led to an Increase in Female Leadership Positions, a 10-year analysis. We have no disclosures to report. In 2017, a JAMA internal medicine study showed that patients who have female physicians had better outcomes with regards to readmission rates. Countries with female leadership also showed better control of COVID-19 spread and deaths. Since 2017, women have represented over half of the incoming medical students in the US, and in the academic year of 2018 and 2019, 31.2% of surgical residents were women. However, women in leadership positions within surgical societies are more disparate and do not reflect the number of women in surgical training. The purpose of our project was to analyze female representation in residence and leadership over the past 10 years within the following surgical subspecialties: general surgery, plastic surgery, cardiothoracic surgery, vascular surgery, orthopedics, neurosurgery, and urology. Leadership positions were defined as executive committee seats for the leading surgical society and the governing board for that surgical subspecialty. Counts of residents and names of society members were collected from 2008 to 2018, and the proportions and rates of change of residents and leaders were compared with bivariate analysis, linear, and logistic regression. In our 10-year aggregate, we noticed that a proportion of women in all surgical leadership lags behind women in all surgical training over the past 10 years. All specialties showed a significant disparity as well between the percentage of women in leadership versus the percentage of women in training, except for orthopedics and neurosurgery. This data chart shows our 10-year aggregate cohort with the bolded values having statistical significance to p less than 0.01. And you can see that all specialties have a significant difference between the percentage of female residents and the percentage of female leaders, except for neurosurgery and orthopedics. Over time, all specialties showed a significant annual increase of female residents except for orthopedics, and all specialties showed a significant annual increase of female leaders except for vascular surgery and neurosurgery. This is our data chart for the annual increase of residents with, again, the bolded values showing statistical significance, and you can see that plastic surgery leads the pack at the highest annual increase of female residents per year. This is our data chart for the annual increase of leaders. Again, the bolded values are statistically significant. And again, plastic surgery leads the pack with a 1.9% increase of female leaders per year. When comparing the annual increase of female residents to the annual increase of female leaders, women in surgical leadership actually increase at a faster rate than women in surgical training when all the specialties are considered as an aggregate. But when broken down by specialty, residents increased faster than leaders in cardiac and vascular surgery, with the remainder of the specialties showing no significant difference between the increase of leaders and the increase of residents. This data slide shows what I talked about in the last slide. Again, the bolded values are individually significant values, and the highlighted green rows show that there is a significant difference between the increase of residents and the increase of leaders. There are limitations to this project. The number of leadership positions that we considered ranged from 20 to 50 depending on specialty, so fluctuations by a single seat changes the percentage significantly. Some leadership positions span multiple years, and residency training also spans multiple years with many non-standard paths, for example, research years or the integrated versus independent tracks. There's also lag time following the graduation of a surgical trainee to the election of a leader on a committee. In conclusion, women in plastic surgery training and leadership positions have shown the greatest increase over the past 10 years compared to other surgical subspecialties. This implies a better considered effort on the part of our specialty to close the gap. However, because there is a gap between the representation of women and men, increased efforts in diversity and inclusion will be beneficial across all specialties. Thank you very much.
The next paper in this session, Controlled Microsurgical Puncture of Vessels to Augment Angiogenesis.
Good morning, everyone. I want to thank you for the opportunity to present our project, which we have titled Controlled Microsurgical Puncture of Vessels to Augment Angiogenesis. Soft tissue loss is often encountered after traumatic injury or oncologic extirpation, and many reconstructive procedures are suboptimal. Grafted tissue constructs are often used for reconstruction, but their success is linked to vascular integration. There is little known about the utility of surgical approaches in facilitating prompt vascularization and perfusion of implanted engineered grafts. We hypothesize that we can expedite the angiogenesis into collagen grafts by mechanically disrupting the vascular wall, allowing for instantaneous cellular extravasation and cytokine accumulation through a process we've termed micropuncture. For this experiment, we used a total of 15 rats. After the animals underwent anesthesia, an incision was made in the hind limbs, exposing the saphenous artery and vein. These vessels were then circumferentially dissected using And using a 60 micrometer diameter needle, we punctured the artery and vein at 1 millimeter intervals for a total of 15 punctures. Successful puncture of the vessel lumen was confirmed with the presence of bleeding. After performing the micropunctures, the artery and vein were stripped to ensure lack of thrombosis and continued distal perfusion. The contralateral limb served as the intrinsic control and was dissected in a similar fashion without micropuncturing of the vessels. Here you can see the relative size of the needle used and the prepared acellular type 1 collagen graft after it was placed over the vasculature here. Afterwards, the incisions were closed and the collagen underlying vasculature were removed after 24, 48, or 72, or 96 hours. And the tissue samples were either prepared for histologic analysis or for Western blotting. Prior to explantation, the 96-hour time group underwent fluorescent vessel angiography with a lipophilic fluorescent tracer dye for whole mount vessel analysis. Micropunctured samples were found to have a greater number of luminal structures with larger diameters, leading to a greater potential perfusible area at all time points. Immunofluorescent staining for CD31 confirmed that these luminal structures were lined with endothelium and represented new vessel formation within the collagen. The higher number of positively stained cells for endothelial markers such as CD31 and von Willebrand factor in the micropuncture group correlated with the Western blot protein quantification. Similar patterns were seen with proteins associated with endothelial proliferation, such as VEGF receptor 2 and TIE2. Lower extremity fluorescent angiography at 96 hours allowed for visualization of the vessels seen here and vessel analysis. First, on the left side, we see images that show the exposed collagen in situ at 72 hours. As you can see, the collagen overlying the micropunctured vessels appeared better integrated with the surrounding tissues and has a large visible new vessel. The right side shows the fluorescent angiogram whole mount images, demonstrating a branch off the main vessel leading to a rich vascular plexus in the micropuncture sample when compared to the control group. The scatter plot demonstrates the differences in the amounts of observable vessels between the two techniques. More than 95% of all observed vessels were less than 50 micrometers in diameter, which is smaller than the 60 micrometer diameter needle that was used for the puncture. Vessel analysis showed that micropunctured whole mounts were found to have a greater vascular density and degree of branching angiogenesis when compared to the control group. In summary, we deduced that with a simple microsurgical technique, rapid and robust angiogenesis could be induced as evidenced by the increased infiltration of proliferative endothelial cells and the increased potential perfusible area. This has the potential application of increasing integration of non-anastomosable grafts, hopefully decreasing the chance of poor outcomes associated with graft vascular integration failure. Further studies are needed to discern the exact mechanism that led to our findings. The increased angiogenesis observed may be due to localized inflammation or the aggregation of extravasated platelets and is likely multifactorial in nature. Thank you very much. That concludes my presentation.
For the last paper of the session, a prospective study comparing breast sensation in neurotized and non-neurotized autologous free flap reconstructions using electronic pressure sensory gradients.
We thank the NSPS for the opportunity to present our work today. We have no disclosures. Decreased sensation is an unwanted outcome following ABR or autologous breast reconstruction. According to some studies, neurotization enhances the magnitude and rapidity of sensory restoration. However, there has been question in a recent meta-analysis in review literature that showed that there is significant methodological variability and inconsistent use of outcome measures, which does not allow to establish meaningful comparisons between studies. Furthermore, most studies have been retrospective in nature and with small sample size, leaving a need for more prospective trials with larger sample size. Therefore, we sought to compare the long-term breast sensation and patient-reported sensation outcomes found in neurotized and non-neurotized ABR. We designed a prospective trial by a single surgeon, including women undergoing unilateral or bilateral ABR with a free flap that were 21 years old or greater, and that were at least 1 year post-op. The advanced allograft was used as a conduit for the neuroraphy between the sensory intercostal and medial intercostal nerves. Clinical data was extracted from the AMR, Sensation data was ascertained using the Acroval pressure-specified sensory device testing. And the testing included 1-point static and 1-point movement. Quality of life was extracted using the rescue questionnaire, and we also included a sensation questionnaire for PROs. The following diagram shows a representation of all the areas that were measured for sensation using the Acroval device. This device provides a number or value between 0 and 100, with 0 representing the highest number for sensation and the lowest sensation being 100. The chart on the right shows the theoretical pressure at which sensation is normal, showing between 2.5 and 5.5. Anything greater than this is considered either diminished or loss of protected sensation. The statistical analysis were as listed. The following table shows all the characteristics between non-neurotized and neurotized patients. There were 93 patients undergoing 155 flaps. There were only differences in terms of race, obesity, and immediate reconstruction, with a greater proportion of immediate reconstruction than in neurotized groups. The following diagram shows the actual sensation results for the 1-point static test, showing increased sensation for the neurotized patient in the superior mastectomy flap and decreased sensation in the inferior mastectomy flap. No differences were observed in other areas or when comparing areas by the 1-point movement test. In terms of quality of life data, the rescue domains that were statistically significant difference between the two groups were the physical well-being in the abdomen lowest scores in the neurotized group, and a higher satisfaction of the nipple areolar complex for those undergoing neurotization. The following table shows that there were no differences in patient-reported outcomes in terms of perceived sensation, numbness, tingling, paresthesia, or temperature perception. However, there was a larger proportion of patients that expressed that their daily life was affected by their sensation in the non-neurotized group compared to the neurotized group. In summary, this is a larger prospective sensation study in the United States for patients undergoing ABR. There are conflicting results in terms of sensation for both neurotized and non-neurotized groups. And the daily life seems to be affected due to sensation for more patients without neurotization. Both groups shows loss of protective sensation in all quadrants, which is important to highlight. We have to acknowledge that this is a non-randomized controlled trial, and therefore is subject to selection bias. And there were baseline differences that we could not control for, and we're working on obtaining a larger sample size for statistical modeling. In conclusion, for the most part, there are no significant differences in sensation between neurotized and non-neurotized patients undergoing ABR. Further research is warranted to account for patient differences between the two groups and determine the true value of neurotization at the time of ABR. There is a loss of protective sensation regardless of neurotization, which speaks to the difficulty of achieving close to normal sensation restoration in ABR. Thank you.
Wonderful, thank you. These papers are now open for discussion, and please feel free to send in your questions in real time for our Q&A area of the format. So we do have some questions in already for Dr. Morano. Are there patients who undergo transitioning before living full-time as their identifying gender?
Yeah, that's a good question. Thanks for the question. I think one of the things that makes this this data set, which I think is extremely useful and important, I talk to use that there is no clear temporal relationships, but it gives you sort of a snapshot in time. So the participants were asked if they currently live full-time in a gender other than that which they were assigned at birth, other than their congruent gender. And it's not to say that the ones that currently don't have in the past, or the ones that don't now, have in the past. And so, it stands to reason that someone who has not who has not sort of come out as transgender couldn't detransition, but it's not sort of a clear sort of temporal relationship. So from this data set, it's impossible to tell whether patients or participants, I should say in this case, had that experience.
Great. I have another follow-up question from Gabriel de Corral. Did you look at any correlation between surgical complications and type of gender-affirming surgery for detransitioning?
Yeah, I would love to have that data. Unfortunately, the kind of the extent of what is asked in this data set is, what surgery have you had? Is it, have you had the surgery? Do you want it? Do you not want it? Maybe you want it someday. And then that's kind of it in terms of surgical data. So the amount of surgical information I have is, have you had surgery? Have you not had surgery? And what are the differences between these two groups? So you can correlate different studies with complication rates from gender confirmation procedures and see if the ones that have higher complication rates have higher rates of detransitioning, but it wouldn't be a direct correlation sort of within this consistent data set.
Great, thank you very much. Next question is for Dr. Hancock from Dr. Lilikos. Concern for thrombosis still seems like a real concern, and she wonders if there's a minimum vessel size to help prevent this.
Sure, thank you for the question. Obviously, anytime we mess with the vessel, we are worried about thrombosis. In our experiment, we specifically looked at thrombosis after the intervention by stripping the vessels. We were also able to visualize the distal blood flow when we did the fluorescent angiography. It actually would make the tails and the hind limbs of the rats turn pink. So it was confirmed that the vessels were not thrombosed after we did it. As far as vessel size, in our experiment, we performed the intervention on the same vessels in all rats, so they're all relatively the same size. Definitely in the future, moving forward, we could see using smaller or larger vessels and see if that impacted distal flow. But as of right now, we don't have an answer to that.
Thank you. Another question for your paper from Dr. Sia. What is the longest time point did you observe for these neocapillaries? And do you have any evidence that these will persist long-term and not just regress after the acute healing phase ends?
Sure. We did only look at the very acute phase from 24 to 96 hours. And we, as I mentioned in my paper, we did show a significant increase in those time points. We are planning on a next experiment looking at more distal time points to see if that difference persists, if it makes a difference in the long run. So that is for the future.
Great. And a final question for your paper, how do you plan, from Dr. Suduth, excuse me, how do you plan to study if the increased vascularization of the graft translates into improved graft function?
Sure. Also, another thing that we actually had performed later is the temperature in situ of the grafts using thermographic imaging, which showed an increase in temperature statistically, and that could correlate with increased perfusion. Again, long-term data is needed to see how well these grafts are actually integrated and perfused in the long-term setting.
Great, thank you very much. For Dr. Yin, there's a question about your work, first commenting on thanking you for this important work. And the question is for Dr. Yin, with a 1.9% increase in women leadership, when will women achieve parity? This person's math says that it will take 200 years. Is that correct? And how can we increase the rate to reach equity sooner?
So that's a lot there. So thank you, first of all, for that question. As you can see from the, well, maybe you can't see it because it got taken away from the screen, but the data shows from 2008 to 2018, the women in leadership increased from 4% to 28%. So assuming that kind of, and the growth that we calculated at 1.9% was an average across all 10 years. And assuming that the growth increases per year as does the percentage, the time to parity would assuming be less than that. My calculation says about 15 years if the rate remains the same. However, we don't know, we can't predict what the rate will be like given the current situation with how many female graduates we have and how likely they are to be elected leaders. So it's just kind of a projection.
Great. And follow-up question, actually for me, how exactly did you define a leadership position? Was it an executive board position, any board position, committee chair position? How does one define that in your study at least?
In our study, they were defined as executive committee seats on the leading surgical society and the governing board for that surgical specialty.
And did you look at just national societies or did you look at regional societies such as ours?
National societies.
Okay. For plastic surgery, was it just ASPS or was it ASAPS as well? Or
it was just ASPS and ABPS.
Great. Thank you very much.
Thank you.
Question for Dr. Shadab. How have you, given the added risk you mentioned of the prophylactic side, How have you changed your preoperative discussions with your mastectomy patients at your institution who are considering prophylactic mastectomy? For the first paper, Dr. Shadal?
Yes.
Great.
Yes, hi, sorry, I was having some difficulty.
problem.
You know, I think that we discussed with them that there's obviously a risk to surgery in general. And, you know, if you've had radiation, you have added risk to the side that has radiation. And then there is not necessarily an added risk, but you have the same risk that you would have with surgery in general by having the other side done. So you still have the risk of surgery, but then if you're concerned about having cancer on the other side at some point, this may be helpful. And if maybe for symmetry purposes, we don't really discuss the symmetry purposes with them, but I've had patients ask about that, and I do think it's something to consider.
So have you changed your actual recommendations about proceeding with prophylactic? Of course, it's ultimately patient choice, but you know, as far as how you steer them, do you tend to steer them more away from it because of this, or not necessarily?
No, not necessarily. I think we just kind of tell them what we found, but we don't really necessarily steer them away from it.
Thank you very much.
Thank you.
For Dr. Rios Diaz, the final paper, question from Dr. Lin. How long of a nerve graft and how many were used for neurotization? Do you anticipate improvement with longer follow-up? And do these results change your indications for recommending the procedure?
Thank you for that question, Dr. Lin. So in regards to the first one, in terms of the length of the graft that was used was 70 millimeters. We do not have the data on the actual length of the nerves that the neurography was performed to. And as far as documentation goes, I'm aware, is only one nerve that was grafted, that was where the neurography was performed. In regards to the second question, in regards to if we anticipate improvement with longer follow-up, at least that's our hypothesis. Our main hypothesis is that the restoration to normal sensation will be quicker with neurotization. And this links to the next question. So far with the data that we do have, we cannot say whether definitively whether we should continue to perform neurotization or not. We definitely need longer follow-up to answer that question. But at least preliminary results, as you can see, are conflicting. So this calls to the question whether are we using the right device to test the sensation and objectively, and even if this is what we're doing objectively, what does that matter to the patient the most? So that's why we include in the rescue component and even the patient-reported outcome component. And as you can see in our results, and this is why we still carry on with the study, patients in neurotized arm are reporting that their quality of life it's improved. So therefore, we're going to continue with the study until we have more power to both control for confounders, and second, to be able to determine whether the restoration of sensation is quicker within a neurotized arm or not.
Great, thank you. And a follow-up question for you. You know, given your findings, have your group reconsidered aspects of the actual technique or your donor site as the potential issue as to why you didn't see as much of a difference?
That's actually an excellent point, Dr. Glatt. I would definitely have to
Not that I would ever question Dr. Suletti, by the way, but just curious.
Yeah, I actually would have to defer that question to Dr. Suletti, because I'm not sure if along the course of the study, the techniques has changed, but it definitely is a constant in the study. And that's one of the things that we could at least get control for, is that the technique will be similar because it's the same surgeon. And
donor site, any thoughts about potential being the issue?
Yeah, it certainly could be an issue. With the data we do have, we cannot answer that question, but it's certainly possible.
Great, and we have time for one more question here, and apologies, there was, well, the question disappeared from my list, so I guess we'll end this session here. We're actually right on time anyway. Thank you so much to all the presenters. These were an outstanding group of papers in the resident competition, and it was extremely hard to select just 10. So thank you again for your work, your excellent work, and for presenting your work to us this morning as part of this. We're going to move on now to the breast session. And I'd like to present our breast moderators, which will be Dr. Mark Smith and Dr. David Song. I see they're both thankfully logged in and it seems ready to go. So I'll turn the program over to them. And thank you for joining us again this morning.
All right. Can you hear us?
I can hear you, Mark.
All right. Hey, hi, David. So I'm Dr. Mark Smith from Northwell. Dr. David Song's my co-moderator. And this, we're going to start the session with the first talk, air versus saline, the effective tissue expander fill on complications in two-stage prepectoral breast reconstruction. Thank you.
Hello everyone, my name is Pooja and I'm a fourth-year medical student at Johns Hopkins. Today I will be presenting our work studying the impact of intraoperative tissue expander fill medium on outcomes of staged prepectoral implant-based breast reconstruction. The authors have no relevant disclosures. Prepectoral staged implant-based breast reconstruction is a well-established technique. In the first stage, a tissue expander is placed in the prepectoral plane after mastectomy, and in the second stage, the expander is exchanged for a definitive implant. Traditionally, saline is used for intraoperative and postoperative expansion. Recently, however, intraoperative expansion with air has been proposed to reduce pressure on the mastectomy skin flap in the immediate postoperative setting. Our study objectives were as follows. First, we wanted to determine the safety of intraoperative air filling. Then, we wanted to determine whether tissue expansion fill medium impacts postoperative complication rates in the setting of prepectoral stage implant-based breast reconstruction. In our institutional protocol, we only used air intraoperatively and immediately postoperatively. Patients were switched to saline at the 2-week postoperative time point, and the remainder of the expansion was undertaken with saline. This was a retrospective review of women undergoing staged prepectoral implant-based breast reconstruction between January 2017 and December 2018. 87 women were included in the final study cohort. Postoperative complications after expander placement were tabulated. Among the 87 women, 33% received intraoperative saline fill, while 67% received air fill. Air and saline fill cohorts were similar in terms of baseline demographics as well as baseline clinical factors. Additionally, air and saline cohorts received similar intraoperative tissue expander fill volumes. Overall, patients receiving intraoperative and immediate postoperative expansion with air had significantly lower complication rates and salvage reoperation requirements when compared to the cohorts who received saline fill. This association remains significant even after adjusting for demographic and clinical factors. In fact, patients who underwent intraoperative and immediate postoperative expansion with air had an adjusted odds ratio of 0.4 for postoperative complications and an odds ratio of 0.4 for salvage reoperation requirements. In conclusion, our data demonstrated that using air instead of saline for intraoperative tissue expansion reduced overall adjusted rates of post-mastectomy complications and salvage reoperations. In the literature, the greatest risk for mastectomy flap necrosis occurs within 2 weeks after mastectomy and tissue expander placement. Thus, by using air expansion in this crucial postoperative time period, our institutional protocol may help relieve pressure on the delicate flap tissue and improve outcomes. There are some theoretical risks of air expansion. However, we did not note any complications that were specific to air expansion in our study cohort. The safety of this technique is further enhanced by the fact that patients only undergo expansion with air for 2 weeks postoperatively, at which point they are switched to saline. Further investigation will be undertaken to characterize the long-term impacts of intraoperative air expansion. Mastectomy flap necrosis is known to impact downstream outcomes of reconstruction, so it will be important to compare time to reconstruction and outcomes after implant exchange in these 2 patient cohorts. We are also currently studying postoperative pain levels in air versus saline cohorts. The study was not without limitations. First, this was a single institution retrospective investigation limiting external validity. However, as a high-volume reconstructive center, our experience may help to provide valuable information with regards to this breast reconstruction technique. Additionally, post-surgical complication rates may vary by surgeon. However, all surgeons in the study followed institutional protocols, and we also found on subgroup analyses that complication rates did not significantly differ between surgeons. Thank you so much to the Northeastern Society of Plastic Surgeons for allowing us to present our work. I'd like to thank my mentors, Dr. Nazarali and Dr. Lee, for giving me the incredible opportunity to take part in this work. I would also like to thank Not at Risk, Dr. Martin, and Dr. Tevlin for their incredible mentorship with this project. Thank you so much.
Okay, thank you. Our next presentation is the impact of pre versus post-mastectomy radiation therapy on outcomes in prepectoral implant-based breast reconstruction.
Thank you for the opportunity to present this research. Prepectoral implant breast reconstruction is being increasingly performed over subpectoral reconstruction because of the reduced invasiveness of the procedure, postoperative pain, and the risk of animation deformity. Radiation therapy is a well-known risk factor for complications in implant-based breast reconstruction. Post-mastectomy radiation therapy has been shown to be associated with higher rates of reconstructive failure, capsular contracture, higher need for revision surgery, and poor cosmetic outcomes. Most of the published literature on radiation therapy and implant-based breast reconstruction involves subpectoral implant-based breast reconstruction. The effect of premastectomy versus post-mastectomy radiation therapy on outcomes after prepectoral breast reconstruction has not been well defined. The purpose of this study was to compare the effect of premastectomy versus post-mastectomy radiation therapy on outcomes after prepectoral implant-based breast reconstruction. A retrospective chart review was performed of all patients who underwent prepectoral breast reconstruction with an inferior dermal flap and acellular dermal matrix performed by the senior author from 2010 to 2019. Outcomes were assessed by comparing complication rates. The prepectoral implant reconstruction technique involves first making a wise pattern mastectomy incision. A deepithelialized dermal flap is then fashioned from the inferior pole breast tissue, and this is sewn to ADM superiorly. The ADM and deepithelialized dermal flap are then sewn to the chest wall. The implant is covered with the deepithelialized dermal flap inferiorly and the ADM superiorly, and the mastectomy flaps are draped over the implant, and the flap is inset with a free nipple graft. On the left is a 65-year-old patient 5 years after bilateral prepectoral implant reconstruction. On the right is a 45-year-old patient 2 years after left unilateral prepectoral implant reconstruction. In total, 369 patients and 592 breasts underwent prepectoral implant reconstruction during the study period. 26 patients and 28 breasts received premastectomy radiation therapy, and 45 patients and 71 breasts received post-mastectomy radiation therapy. 305 patients and 493 breasts did not receive radiation therapy. When comparing premastectomy radiation therapy versus non-radiated patients, it was shown that premastectomy radiation patients had a higher rate of minor infection, 10.7% versus 1.2%, seroma, 14.3% versus 0.2%, implant loss, 21.4% versus 3.4%, and local recurrence, 7.1% versus 1%. When comparing post-mastectomy radiation therapy versus non-radiated patients, it was shown that post-mastectomy radiation patients had a higher rate of major infection, 8.4% versus 2.4%, capsular contracture, 19.7% versus 3.2%, implant loss, 9.9% versus 3.4%, and local recurrence, 5.6% versus 1%. When comparing premastectomy radiation patients versus post-mastectomy radiation patients, it was shown that premastectomy radiation patients had a higher rate of seroma, 14.3% versus 0%. Outcomes were otherwise comparable between premastectomy and post-mastectomy radiation patients. In conclusion, compared to non-radiated patients, premastectomy radiation patients had higher rates of minor infections, seroma, implant loss, and local recurrence. Post-mastectomy radiation patients had higher rates of major infection, capsular contracture, implant loss, and local recurrence compared to non-radiated patients. Patients receiving premastectomy radiation therapy had a higher rate of seroma compared to post-mastectomy radiation patients. Outcomes between premastectomy and post-mastectomy radiation patients were otherwise comparable. The study is limited by the non-randomized retrospective design, as well as the low number of patients in the premastectomy and post-mastectomy radiation groups. A larger randomized control studies are needed to determine the effect of premastectomy versus post-mastectomy radiation therapy on outcomes after prepectoral implant reconstruction. Special thanks to Dr. Ankia Young for letting me present her incredible results, along with her colleagues, Dr. Mary Pranavast and Dr. Christine Hoyle. And thank you, Dr. Sarah Persing, Dr. Robin Wu, for helping me with this presentation. Thank you very much.
Hello, my name is Ashraf Patel, and I'm a fourth-year medical student at SUNY Upstate Medical University. We'd like to thank the scientific committee for giving us the opportunity to present. Today, I'll be discussing our research that looks at wise pattern reduction reconstructions and a project specifically that aimed to test whether ADM is necessary when using a novel ADM sparing technique. We have no relevant financial disclosures. The wise pattern mastectomy is an option for patients with a confirmed breast cancer diagnosis or patients desiring a prophylactic mastectomy. Specifically, it's for patients who are desiring a reduction as well as a reconstruction, and this tends to be obese patients or those with very tonic breasts. Studies have shown that this skin incision in form of mastectomy can provide a better aesthetic result compared to the nipple-sparing mastectomy in this specific patient population. Because the wise pattern incision removes so much tissue, it can be associated with high complication rates, and ADM is often used to help address this issue. However, ADM does have its own drawbacks, including significant costs, and studies have also shown it is thought to be seromogenic. It's also thought to be the cause of red breast syndrome, which is thought to be a delayed type hypersensitivity against ADM and is seen on the image here in the right. When the wise pattern mastectomy is used, we're left with a dermal flap that can be utilized. In the top left here, we see the wise pattern skin markings, and this is the area that is deepithelialized. Once the mastectomy is complete, this will result in a dermal flap. At our institution, reconstructions are predominantly done in the prepectoral plane, and when a reduction reconstruction is undergone, the expander is covered with ADM and then placed in the breast pocket. The dermal flap that we saw in the previous slide is then draped over this, and the breast pocket can be closed. Since the expander is getting coverage by both the ADM and the dermal flap, this can be seen as a little redundant, and to limit this, we introduce a novel ADM sparing technique that I'll describe in the next few slides. Our project aimed to test the safety and efficacy of our novel ADM sparing technique as compared to the traditional technique that utilizes ADM. This was a retrospective cohort study, and the two cohorts were determined based on whether ADM was utilized in the reconstruction. This was a single surgeon experience over about a 3-year time period. Our technique utilizes the deepithelialized flap alone without ADM to secure the tissue expander at stage 1. We do this by suturing the apex of the flap to the superiormost tab of the expander, and once the expander is secured, it can then be expanded. To secure the expander, the lateral most aspect of the flap is freed and rotated superiorly to form a very nice lateral border to help form the breast pocket and keep the expander in place. This is seen here where this aspect of the dermal flap was freed and then rotated superiorly. In this image, you can also notice that the dermal flap does not need to be entirely covering the expander, but simply a majority of the expander is covered. Here we see that the medialmost aspect of the expander is not covered. This is the same patient seen at stage 2 of reconstruction. This is an inferior view, and then here, after the incision is made, we can see the tissue expander filled with saline. Once the expander was removed and the SPY device is utilized to get a view of inside the breast pocket, we can see that the breast pocket is very nicely formed, including the medialmost border, which was previously not covered with the dermal flap. Here's the data from our study, which included 85 patients and 164 breasts. We had 35 patients in the ADM cohort and 50 in the non-ADM cohort. Overall, comorbidities did not vary significantly, but for the few that did vary, we ran multivariable regressions and none were found to be predictors of complication incidence at both stage 1 and stage 2 of reconstruction. When looking at the complications, we see that at stage 1, our overall complications were similar at 32 versus 35%. The only individual complication that was significantly different was minor infection, which we found to be more prevalent in the ADM cohort, and this was statistically significant. At stage 2, we found that complication rates were overall similar, with none varying significantly between cohorts. From our study, we found that overall complication rates are similar with and without ADM. Minor infection rates were higher at stage 1 when ADM was utilized, and this was statistically significant. Therefore, we find that the de-epithelialized dermal flap provides ample prosthesis support for patients desiring a reduction reconstruction, and this technique may lead to large cost savings. Here is a pre- and post-operative image of one of our patients who had a very successful outcome. Thank you for your attention.
All right, thank you. Our next presenter is going to be speaking about nipple-sparing mastectomy and immediate implant-based breast reconstruction, propensity-matched analysis of clinical and health-related quality of life outcomes. Thank you.
Hello, everyone, and thank you for the opportunity to present our research. The title of my talk is Nipple-Sparing Mastectomy and Immediate Implant-Based Breast Reconstruction, a propensity-matched analysis of clinical and health-related quality of life. Nipple-sparing mastectomy rates are constantly increasing over the last 20 years. Nipple-sparing mastectomy is being utilized for selected candidates with breast cancer and for those in need for risk-reducing surgery. The safety of nipple-sparing mastectomy is well studied. The oncologic outcomes, as reported by recurrence rates and overall survival, as well as postoperative complications, are comparable to conventional mastectomy types. It is believed that nipple-sparing mastectomy, through maintenance of the nipple areolar complex and the breast envelope over the reconstructed breast, achieves a more natural appearance and therefore leads to superior psychological and cosmetic outcomes. Although safety and outcomes are well studied and comparable, not much is known about patients' perceptions about outcomes. Patient-reported outcomes, as captured by the breast-Q module, are promising, but there are profound limitations to the existing studies, such as sample size, heterogeneous study cohorts, and the retrospective nature of those studies. Our study was approved by our institution's IRB. The study period was from 2007 to 2017. The study population is consisted by patients undergoing nipple-sparing mastectomy or skin-sparing mastectomy for prophylactic or therapeutic indications. Excluded were patients with a history of preoperative radiation, unilateral reconstruction, missing bra size data, as well as the ones that underwent delayed breast reconstruction. Postoperative complications were recorded. Breast reconstruction-related patient-reported outcomes were assessed using the reconstruction module of the breast-Q. Patients were administered the breast-Q preoperatively as well as postoperatively at 3 months, 6 months, 1 year, and up to at least 3 years. A propensity score matching 1-on-1 was performed to balance possible confounders. In the unmatched cohort, total 1,717 patients were found that underwent nipple-sparing mastectomy and skin-sparing mastectomy, followed by bilateral implant-based reconstruction with at least one postoperative breast Q survey. After propensity matching, 488 patients were included, 244 patients in each cohort. There were no differences in demographics between the two matched cohorts. The total number of complications and the types of postoperative complications did not significantly differ between the two cohorts. The most common surgical complication in both cohorts was mastectomy flap necrosis, followed by breast cellulitis and breast seroma. Comparing breast Q patient-reported outcome scores between nipple-sparing mastectomy and skin-sparing mastectomy patients for all domains and at all time points, no statistically significant differences in scores were noted. In this graph, as you can see, nipple-sparing mastectomy patients preoperatively, as well as at 3 years, as shown in the blue and orange graph respectively, remain stable. Likewise, skin-sparing mastectomy patient-reported outcomes preoperatively and at 3 years, as shown in the yellow and gray graphs respectively, were stable as well. As a conclusion, nipple-sparing mastectomy in the right candidate is becoming a commonplace. There is an established consensus for its safety regarding oncologic outcomes and morbidity profile. The concept of improved aesthetics is commonly stated as the primary motivation for performing nipple-sparing mastectomy. In our study, however, nipple-sparing mastectomy did not confer superior patient-reported outcomes in all domains. Breast Q scores remained stable throughout the 3-year period of data collection for both cohorts. Complication rates and types of complications also did not demonstrate any differences. Our study has some strengths. This is one of the largest studies that are reported in the literature. Additionally, we performed the propensity score matching analysis of prospectively collected patient-reported outcome data. This analysis approach accounts for confounding variables and is the next best approach to randomization. Our results can be used to guide patient education before selection of nipple-sparing mastectomy versus skin-sparing mastectomy. There are some limitations to our study. The breast Q module does not include questions about the nipple areolar complex. Therefore, there is a potential lack of sensitivity to capture aesthetic differences based on presence or absence of the nipple areolar complex. Furthermore, there may be a health responder bias with the patients completing the breast Q, as not every patient completed all modules at all times. This is also a retrospective study with a potential bias regarding which patients underwent skin-sparing mastectomy versus nipple-sparing mastectomy. There is definitely a need for a nipple areolar complex specific domain in breast Q, and to our knowledge, the development of one is underway. Thank you.
All right, thank you. And I encourage our, our audience to submit questions in the chat. Thank you. Abdominal wall thickness versus BMI as a predictor of complications after abdominally based free flaps to treat mastectomy defects will be our next presentation.
Hello, my name is Adi Hyman. I'm a second-year resident at Albany Medical Center, and I'm here to present our research on abdominal wall thickness versus BMI as a predictor of complications after abdominally based free flaps. Some background. Over the last decade, the rate of microvascular breast reconstruction has more than doubled, and some reasons for this include decreased cost, concerns about breast implants associated ALCL, superior outcomes with autologous reconstruction in patients who require radiation, and the inadequacy of available implant sizes in obese patients with large product breasts who require reconstruction. However, there is still that question, is microvascular breast reconstruction appropriate in obese patients, with some people considering a BMI greater than 35 a relative or absolute contraindication to free flap reconstruction. Some studies have shown an association between higher BMI and complication rates. However, there have been studies that have challenged that, such as Timmermans and Motoresi, who showed no significant difference in mean BMI between patients who did versus those who did not experience postoperative complications. So is BMI the best predictor of complications after abdominally based free flaps? And if not, is there a better alternative measurement we can use? We conducted a retrospective chart review on 151 patients at our institution who underwent abdominally based free flaps to treat mastectomy defects. We looked at 25 distinct points across the abdomen. And given that we only have 5 minutes, then we're only going to be discussing 2 of those points. C3, which represents the umbilicus, and E3, which is 8 centimeters inferior to that. So we measured them on the pre-op CTA by measuring the vertical distance between the skin and the muscular abdominal wall. So what we found was that mean BMI did not differ significantly between patients who did and did not experience complications. And that was true for any type of complication, for complications specific to the abdomen, and for complications specific to the breast. However, when we looked at the abdominal wall thickness at the umbilicus, we found that that did differ significantly in patients who either did or did not experience overall complications or did or did not experience abdominal complications. When we looked at the lower abdominal wall thickness, that measurement differed significantly between patients in all 3 comparison groups. So looking specifically at subtypes of abdominal complications, there were significant differences in the mean lower abdominal wall thickness seen between patients who did and did not have complications requiring reoperation and patients who did and did not have abdominal wound healing complications. And when we looked at complications specific to the breast, the only group where we found a significant difference in the mean lower abdominal wall thickness was in patients who did and did not experience wound healing complications related to the breast. So looking at this from the opposite perspective, can we predict complication rates based on lower abdominal wall thickness? And the way we did this was we stratified all of our patients into 4 groups based on that lower abdominal wall thickness measurement. And what we found in terms of abdominal complication rates was that the rate of abdominal complications increased in a statistically significant linear fashion across the 4 groups, not only in terms of overall abdominal complications, but in terms of whether or not those complications required surgical intervention. So as you can see from the orange, those are the complications requiring surgical intervention, which those rates did increase across the 4 groups. We also found a statistically significant difference that increased across the 4 groups in wound healing complication rates, however, not in infectious complications. Looking specifically at breast complications, as you can see, there is not a statistically significant increase in breast complication rates, although it does seem like the rates are higher in those higher LAWT groups. And similarly, there's no statistically significant differences in wound healing complication rates, fat necrosis rates, or infectious rates. However, those did seem to increase among the first 2 groups when looking at the groups, even though that didn't reach statistical significance. So our data is consistent with the fact that lower abdominal wall thickness is a better predictor of complications after abdominally based breast reconstruction compared to BMI. Further studies will obviously need to be done. But for now, thank you very much for your attention.
Thank you, Dr. Hyman. Okay, so that concludes the first part of that session, and we're going to be opening up the Q&A. Again, I just want to remind our audience to submit via the chat any questions that you may have. Dr. Song, are you there? Do you want to start with the questions?
Yeah, I have a question to start off with the second case, the WISE. It said that you use the inverted T or WISE pattern for all your patients. What happens to patients that don't have ptosis and don't require an inverted T or a WISE pattern? What do you do in those situations?
That's for Dr. Sinat. Please unmute. If you're muted, you may be muted.
I'm sorry, could you repeat the question?
Yeah, so in your cohort, you said that all the patients had an inverted T
Right. Mastectomy.
What happens to those patients that have no ptosis and don't require an inverted T?
Right. That's actually, she does a modified WISE pattern or a WISE pattern for pretty much all of her prepectoral cases. And yeah, that's a good question. I guess she doesn't, I don't know exactly how she would modify the technique for a patient who doesn't have.
Yeah, what if they're small? Okay. Yeah, because there's obviously some patients that don't have ptosis and don't require an inverted T.
Right.
So that would be an interesting thing to think.
That's great.
The second question is, the second question is for paper 11. After the saline is added to the air tissue expander, were there any complaints of sloshing?
Thank you so much for the question. Actually, I should clarify that at the 2-week postoperative time point, the air was removed from the expander and an equivalent volume of saline was replaced. And we actually did not notice any patient complaints of sloshing per the reports.
I have a question, actually.
That was a question as well. It sounds like you answered that. Mark.
Sorry. Yeah, I have a question, actually, again, just to follow up for presentation 12. It looked like all the reconstructions were direct to implant. And in those patients, you had some that were radiated and without the ADM in there and prepectoral location. Just curious about the incidence of capsular contracture and also whether you would have considered a tissue expander in those patients who might get radiated.
Yeah, she does mostly direct to implant reconstructions for most of her cases. And she only really uses expanders for patients who want to be larger, to have larger breasts. you know, in regards to your question, so basically, you know, some patients received pre-mastectomy radiation therapy and some patients received post-mastectomy radiation therapy. So, and they all pretty much 95% of them all had direct to implant reconstructions.
So was capsular contracture an issue in the radiated subgroup? It seemed like it was low.
Capsular contracture was lower in the pre-mastectomy radiation group, and it was higher in the post-mastectomy radiation group. It was about twice as high as that.
Okay. Let me just see if any other questions from our audience.
There's a question from Dr. Gabe Del Corral about the perfusion of mastectomy flaps with air versus saline and imaging device to look at that.
Thank you so much for your question. It's a great question. And unfortunately, we did not look at the perfusion with ICG angiography, but that's a great suggestion for future studies. The perfusion in our study was mostly just determined by clinical assessment.
Thank you.
Great, thank you. Mark, any questions from your end?
Yeah, I have a question for Dr. Kokosis regarding the breast Q and looking at the nipple-sparing mastectomy and skin-sparing mastectomy outcomes. And since the satisfaction rates were similar between the groups, would you conclude that there's no benefit to doing nipple-sparing mastectomy? Or is this highlighting a shortcoming of the breast Q in terms of assessing aesthetic outcomes when patients may not know the difference between what they were treated with and some other form of treatment? Thanks.
Thank you. Yeah, this is a great question. Breast Q is the best tool, a validated tool that we have at our disposal. And so that's what we're using when we are assessing patient-reported outcomes. I do, however, believe that there's a limitation. The only question that exists in the breast Q module about the nipple areolar complex is one question about the satisfaction with the reconstruction after nipple reconstruction. And so technically, patients who have their nipples preserved, they don't qualify for the breast Q based on the questionnaire. Again, as I said in my presentation, I know that Dr. Pusick is working on creating a module, adding a module to the breast Q that addresses the nipple preservation. It is important, though, to use any tool that we have at our disposal when we educate patients. And so far, this is what we have. If patients without nipple preservation were not happy, based on the validation survey that we have, we should know that. And so if I were to see a patient at this point in time, in my office, and educate them about whether they should have a nipple-sparing mastectomy or not, I would say that patient-reported outcomes are not better at this point.
Okay. Do you think that takes into account the fact that a patient, if they're not presented the option of nipple sparing, may not be aware that there may be another option? I think this becomes one of the challenges that patients often have, is that they have a limited perspective on, and by comparison, if they run into another person who had their nipples shared and then took the questionnaire, they may be wondering, why couldn't I have had my nipple preserved? So I don't know if you can answer it, but I just wonder if there's a way within the questionnaire or if there's another element of the questionnaire that accounts for this.
No, I agree with you. And again, I think that just highlights the limitations of breast Q. And so hopefully in the future, we will be able to address this.
Okay. I think just to round out for Dr. Hyman, why do you think that in your study, BMI was not associated with increased risk and complications? I think for many of us, that's been an experience where we feel that there is a correlation. And why do you think the points that you selected are correlated with different outcomes? What is it about the abdominal wall thickness that Is it a surrogate for some other condition that we're not measuring with just BMI? Is it the relative amount of subcutaneous versus intra-abdominal fat? And just interested in your thoughts in terms of why we would see the discrepancy.
Thank you very much for the question. I think the reason we weren't seeing the difference in the BMI was that BMI is somewhat of a flawed measurement in that it doesn't really, it looks at sort of total body mass versus height, but doesn't really compare specific types of fat distribution. Whereas our measurement was more specific to the actual distribution of fat that was going to be, since the measurement we were most interested in was the lower abdominal, that's a point that's going to be both part of the neo breast flap, as well as the thickness of that lower abdominal wall is going to be reflective of the thickness of the lower aspect of the abdominal incision. So that potentially could mean a thicker and therefore heavier, I guess, weight on that, abdominal closure, which that, effect maybe due to gravity might be putting more tension on your incision. And that's just a more direct way of measuring sort of, I guess, what ideally BMI is supposed to measure is, the fat content of the body. So I think that's why we saw more of a difference with that specific measurement.
Okay, thank you. In the interest of time, I don't know, I think we got to move on to the next round of presentations. I want to thank all the presenters on for their excellent work. Thanks.
Thanks.
Thank you. So let's go back. Can we load up the next presentation? Our next presentation is going to be disparities in nipple-sparing mastectomy and lessons learned from 1,202 mastectomies within a single health system.
Good morning, everybody, and welcome to my virtual podium presentation. My name is Tanvi Singh. I'm a third-year medical student at Georgetown University, and I'm so excited for this opportunity to share with all of you my research on disparities in nipple-sparing mastectomy, lessons learned from 1,202 mastectomies within a single health system. Nipple-sparing mastectomy is a surgical technique that preserves the skin envelope along with the nipple areolar complex. Research has shown that it is an oncologically safe modality that has superior aesthetic results and high patient satisfaction. In light of this, the inclusion criteria of candidates is expanding, and the rates of nipple-sparing mastectomy is increasing across the United States. However, this increase has not been uniform across the country. The question I hope to answer for you today is why? What is the missing piece of the puzzle? Are there multi-level factors that drive disparities in nipple-sparing mastectomy receipt and delivery across the United States? And what I mean by multi-level is, are there factors at the patient, disease, provider, and healthcare system level that are shaping these disparities? This was an IRB-approved retrospective review of all patients undergoing mastectomy within a single health system made up of 8 academic, community, and urban hospitals within the District of Columbia and Maryland regions. 1,202 mastectomies were performed between 2014 and 2018, out of which about 32% were nipple-sparing. We performed multivariate and bivariate analyses of factors at different levels, such as demographics and comorbidities of the patient level, oncologic and reconstructive details at the disease level, provider demographics, practice type, and race congruence, which we defined as whether the surgeon and the patient were of the same race, and lastly, distance, location, and insurance at the system level. What we found is very interesting. At the patient level, we found that the odds of NSM decrease with increasing age. At the disease level, we found that the odds of NSM decreased with an increase in breast cancer stage. At the provider level, we found that race congruence was associated with increased likelihood of NSM. And we also found a significant between surgeon variation in nipple-sparing mastectomy delivery.
Lastly, we did not find any variables to be statistically significant on multivariate analyses at the system level. So what is the bottom line? The key takeaway is that there are multi-level factors that exist and interact with one another in complex ways to shape the disparities in nipple-sparing mastectomy. So what do these findings mean? As we all know, there are several variables that impact healthcare delivery. In our analysis looking at nipple-sparing mastectomy delivery specifically, we found that patient and surgeon-specific variables were paramount. Patient-level factors are in accordance with previous research. However, this data adds granularity to the surgeon-specific characteristics that drive these variations in nipple-sparing mastectomy delivery. I do want to acknowledge that it is possible that the scope of our quantitative analysis did not capture all of the factors behind this disparity. So I believe qualitative research would be particularly valuable in helping us understand patient preferences and decision-making. In conclusion, we found that there is significant variation in NSM use even within a single health system. Distinct institutional and professional norms are inevitable, but it is critical that we address these barriers to care to ensure a more equitable delivery of an oncologically safe and aesthetically superior surgical modality to all our patients. I hope that these findings lay a groundwork for addressing these barriers and also helping us shape points of intervention that target resources and meet quality of care goals and reduce disparities. Thank you so much for your attention.
All right, thank you. Our next presentation is fat graft only breast reconstruction with and without buried dermatocutaneous flaps, a minimally invasive approach.
Morning. No disclosures. There's a need for a minimally invasive autologous breast reconstruction technique, especially given Allergan's recent implant recall and the FDA's current position on ADM use in the breast. Current abdominal flap-based reconstructions have prolonged operative times and recoveries and varying degrees of donor site morbidity. So what are the other options? Curry et al. Published their fat graft-only technique using Brava in 2015, and Richardson and Ma published their Goldilocks mastectomy technique in 2012, but each one has certain limitations. Our technique in patients with adequate breastosis combines a buried dermatocutaneous flap and immediate adipocyte transfer to create a breast mound that can be enlarged further in a delayed fashion, DCAT for short. Fat graft alone is used in patients without enough ptosis. To mark for the DCAT, we mark a wise pattern mastectomy, harvest fat with PAL, gravity separates the aqueous layer, and we re-inject with a 14-gauge cannula. Intraoperatively, the infrally-based DMC flap is fat grafted, as is the pectoralis. The upper third of the skin flap is folded over and secured to the pec, and skin redraped is seen on the right. Another intraoperative photo showing the fat grafted DMC flap and the fat grafted pec. Photo on the right shows skin redraped in preparation for free nipple grafting. 43% of our DCAT patients underwent immediate free nipple grafting, 36% of all reconstructions, but none in radiated patients. This is a 74-year-old patient undergoing bilateral single-stage reconstruction with DCATs and free nipple grafts. Here she is 7 months postoperatively. Her surgery took about 4 hours and she was discharged home the morning after surgery. We present 78 consecutive reconstructions, 55 of which were DCAT in 47 patients, 18% were radiated. On average, 2 additional outpatient fat graft sessions were required to complete the reconstruction, and our mean volume of 217 cc's of fat transferred per DCAT per breast as an outpatient compared well with Corey's 225 cc's per breast using Brava. 12% of our patients developed palpable fat nodules, which was consistent with literature. Numerous studies have documented the safety of fat grafting in breast cancer patients. We won't review this. Some clinical cases. A patient with prior right breast cancer that required left mastectomy as well. She was reconstructed with fat only on the right side due to lack of skin and DCAT on the left. Photo on the right side shows her 2 years, 4 months post-DCAT and 1 year following her last bilateral fat grafts. This is our 74-year-old patient that underwent single-stage bilateral reconstruction. Photo on the right is 7 months post. Bilateral mastectomy patient that underwent bilateral DCATs with free nipple grafts. Photo on the right is shown 3 years following bilateral DCAT and 9 months following her second outpatient fat graft. Bilateral mastectomy patient reconstructed with bilateral DCATs. Photo on the right shows her 20 months post DCAT and free nipple grafts, and 1 year following her second outpatient fat graft. Bilateral areolar sparing mastectomy patient reconstructed with DCATs that required unexpected PMRT. Center photo shows her following radiation. Photo on the right is 3 years following DCAT and 1 year following third outpatient fat grafting. Radiated patients are hard. Don't start with radiated patients if you're going to use this technique. Bilateral areolar sparing mastectomy patient reconstructed with bilateral DCATs. Patient on the right is shown 3 years, 8 months following DCAT and 2 years, 8 months following her last fat graft. Today, we would have performed free nipple grafting on this patient at the time of her mastectomies, but we were more conservative early in the series. She looks reasonable in a bra. Last clinical case, bilateral mastectomy patient reconstructed with bilateral DCATs and free nipple grafts. Photo on the right is 2 years post-DCAT and 1 year following her last and second outpatient fat graft. Our DCAT technique differs from existing fat graft-only techniques because the buried vascularized DMC flap allows for transfer of larger volumes of fat in a delayed fashion without the need for external expanders or an increase in fat nodule formation. However, not all patients are candidates for the technique. They need adequate brustosis and fat donor tissue. Meticulous preservation of mastectomy skin subcutaneous fat is required, and there's uncertain applicability in radiated patients. Disadvantages of the DCAT and fat reconstruction are the reconstructed breast lacks the projection of an implant reconstruction and requires an average 2 additional sessions to complete, and the jury's still out if we're going to recommend this in radiated patients. The advantages are that it's minimally invasive, requiring only an overnight stay. It's completely autologous, has short operative times. We averaged 3.7 hours for bilateral DCATs, which included the mastectomy. All plastic surgeons can do it, and there's limited to no donor site morbidity. We continue to view fat graft reconstruction, especially the DCAT, favorably after using it for over 3 years. And our consecutive case series was published in PRS Global Open in 2019. Thank you.
All right, thank you. Our next presentation is nipple delay may optimize nipple sparing mastectomy outcomes.
Hello, everyone. My name is Phoebe Lee, and I'm a current medical student at the University of Pittsburgh. I'm here today to present my research, Nipple Delay May Optimize Nipple Sparing Mastectomy Outcomes. Breast cancer is the most common non-skin cancer in women worldwide. Skin and nipple sparing mastectomies are common approaches for breast cancer treatment or risk reduction surgery. Nipple sparing mastectomy, or NSM, can provide women with an optimal reconstructive aesthetic outcome. NSM doesn't come without risks, as necrosis of NAC and surrounding skin flaps have been reported from 6 to 30%. Increased rates of NAC necrosis have been associated with risk factors, including ptotic breast, periolar scars, large cup size, and previous radiation. Use of a nipple delay procedure has been shown to improve viability of the NAC in these NSM patients. Preparatory mammoplasty can also convert patients with moderately large and orthotic breasts into better candidates for NSM. This, however, creates periolar scars that may jeopardize the NAC viability. Therefore, the nipple delay procedure may be particularly useful in mitigating risk in these patients. The nipple delay procedure involves separation of the NAC from the underlying breast parenchyma about 2 weeks before the NSM procedure. And this is done to improve the collateral vascular supply of the NAC prior to the mastectomy. The purpose of the study is to report results from our institution in patients undergoing the nipple delay procedure. We conducted an IRB-approved retrospective review of all patients at the University of Pittsburgh Medical Center who underwent the nipple delay procedure followed by NSM. And this was done from 2013, which is the day we started incorporating NDs in practice, until 2018. Patients who are candidates for nipple delay included patients who have breast scars, history of radiation, and or are current smokers who are deemed higher risk of NAC complications. Candidates also included those who desired NSM but had significant ptosis or large breast volume and underwent preparatory mammoplasty. We identified 22 patients who underwent the nipple delay procedure followed by NSM and 175 patients who underwent NSM only. There was no statistical difference found between the delay and NSM only groups in average age, smoking, history, diabetic status, or radiation, either past exposure or post-mastectomy radiation. Of note, a greater portion of delay patients received NSM for prophylactic treatment. Meanwhile, higher rates of NSM only patients were diagnosed with breast cancer. Over twice the percentage of delayed patients underwent a prior breast surgery compared to NSM-only patients. And of those who had prior breast surgery, over 10 times the percentage of delayed patients underwent preparatory breast surgery as compared to NSM-only patients. And the preparatory breast surgery was usually done to optimize candidacy for NSM. The delay group had greater ptosis grades and heavier mastectomy specimen weights than the NSM-only group. Categorized by breast, most in the delay group had higher ptosis of grades 2 and 3. Meanwhile, most in the NSM-only group had lower ptosis grades of 0, 1, and pseudotosis. Breast weights in the delay group were heavier compared to patients in the NSM-only group, with and without including preparatory mammoplasty weight. The average time between preparatory mammoplasty and the delay procedure was 109.5 days. All of these preparatory mammoplasties were in patients receiving prophylactic mastectomies. The average time that passed between the nipple delay and the NSM procedures was 16.1 days. To determine the average delay in NSM treatment in patients with breast cancer, the time between plastic surgery consult and NSM was calculated for breast cancer patients only, and patients undergoing neoadjuvant chemotherapy and prophylactic NSM were excluded. There was no significant delay from plastic surgery consult to NSM between the two groups. The nipple delay group had an average of 42.2 days, while the NSM only group had an average of 37.1 days. The delay group and the NSM only group do not differ statistically in rates of complications of NAC necrosis, skin necrosis, infection, implant loss, seroma, or hematoma. Of note, not one delay patient had total nipple loss or implant loss. We demonstrated in nipple delay patients no NAC loss in patients with significant breast ptosis, higher mastectomy specimen weights, and previous breast surgery, all without a significant delay in treatment. By using nipple delay, often with preparatory mammoplasty, more women may be NSM candidates while maximally protecting the viability of the NAC. Thank you for listening to my presentation, and if you have any questions, please do not hesitate to ask.
All right, thank you. And again, I want to remind people to submit questions via the chat. The next talk is going to be Do Racial Disparities in Outcomes in Reduction Mammoplasty Exist? A Propensity Matched Analysis.
Hello, my name is Ida Kadakia, and I'm a fourth-year medical student at University of California, Riverside School of Medicine. I will be presenting our project on racial disparities in surgical outcomes after breast reduction surgery. Racial disparities in surgical outcomes have been well documented in literature. In plastic surgery, research on racial disparities has mainly focused on reconstructive breast and craniofacial procedures. In craniofacial surgery, racial disparities have been reported in surgical outcomes of craniosynostosis and cleft palate repairs, with more adverse outcomes reported in Black patients. Insight from research in breast cancer surgery has found that racial and ethnic minority patients are more likely to have lower quality care, have increased biopsy diagnosis to surgery time, and have lower post-mastectomy reconstruction rates. Despite these variations, recent reports indicate that non-white patients undergoing post-mastectomy breast reconstruction have similar or better outcomes than white patients. Given the existence of such differences in reconstructive plastic surgery, racial disparities in outcomes of cosmetic plastic surgery procedures must be explored. In this study, we aim to use the American College of Surgeons National Surgical Quality Improvement Program database to evaluate whether racial disparities in surgical outcomes exist in breast reduction surgery. We've reviewed the ACS NESPS database from 2005 to 2018 to identify all primary encounters for breast reduction surgery. We included all female patients that underwent the procedure for cosmetic reasons. To compare the outcomes in white versus non-white patients, we performed a propensity score matching. The propensity score was derived from a logistic regression model. All significant predictors were included in the propensity score model. In total, 23,268 patients met inclusion criteria. In the pre-matched cohort, there were significant differences in comorbidities. Non-white patients were more likely to have higher BMI, diabetes, hypertension, poor nutrition, higher ASA status, inpatient admission, and younger age at surgery. After one-to-one propensity score matching, 14,374 patients were included in the analysis, around 7,187 in each white and non-white cohort. In the matched cohorts, there were no significant differences in major complications like organ space infections, return to the operating room, or death. There were significantly fewer minor complications in the non-white cohort, particularly superficial surgical site infections were much lower in the non-white cohort. For medical complications, pulmonary, renal, cardiovascular, and septic complications were similar in white and non-white patients. Analysis of temporal trends identified an overall rise in the number of patients seeking breast reduction surgery, with a higher increase noted in the non-white population. This study highlights that the overall post-surgical complications after breast reduction surgery are comparable in white and non-white patients. A lower rate of minor complications in the non-white cohort may be attributed to poor post-surgical follow-up in these patients and easier recognition of redness and superficial site infections in white patients. Increasing patient numbers in the non-white population for breast reduction surgery in the last 15 years might indicate the beginning of an improved access to quality of life improving plastic surgery procedures. However, a continued progress and joint effort is crucial to overcome disparities and ensure equity in healthcare quality. Thank you.
All right, thank you. Our next speaker is going to present how does enhanced recovery pathway impact the outcomes of microsurgical breast reconstruction.
Hello, my name is Malki Assad, and I'm a research fellow at MD Anderson. Today, I'll be talking about the Enhanced Recovery After Surgery Pathway, or ERAS, for microsurgical breast reconstruction. We don't have any relevant disclosures. The use of ERAS protocols has gained popularity in the last few years in microsurgical breast reconstruction. Prior studies have shown decreased opioid use and length of stay in the ERAS group compared to the conventional treatment. However, prior studies has been limited to the outcomes of small group of microsurgeons. The implementation of perioperative protocols in a large and diverse group of surgeons is more challenging, given the heterogeneity of surgical techniques and compliance which might yield different outcomes. The goal of this study is to report our experience with the use of ERAS protocol in microsurgical breast reconstruction and assess the impact of anesthesia type on opioid consumption. We conducted a retrospective review of patients who underwent microsurgical breast reconstruction at our institution. The ERAS protocol was adopted in August 2019, and patients were included in the ERAS group if they underwent surgery between August and December of 2019. The ERAS group was compared to a historical cohort of patients who underwent surgery between June and December of 2018, prior to the implementation of the ERAS protocol. The period between January and July of 2019 was considered as a washout period. Complications were classified based on the Clavin-Lindo classification as minor, grade 1 and 2, or major, grade 3, 4, and 5. The dosages of various opioid medications in the postoperative period were transformed into the oral opioid morphine milligram equivalent. Here is our ERAS protocol. A total of 169 patients underwent microsurgical breast reconstruction during the study period. 58% were in the conventional cohort and 42% were in the ERAS cohort. Patient characteristics were similar between the two groups. Deep flap was the most common type of flap in both groups. Complication rate was significantly higher in the conventional cohort, 34% versus 17% in the ERAS group. No flap failures were identified in either group. Length of stay was slightly shorter in the ERAS cohort. The average total opioid use, as measured by the morphine milligram equivalent, was significantly lower in the ERAS group. When looking at opioid consumption in each of the post-operative days, average morphine milligram equivalent was significantly lower in the conventional cohort on post-operative days 1 and 2. Despite lower opioid consumption in the ERAS group, average pain scores were similar between the two groups in each of the post-operative days. Peak pain scores were also similar between the two groups, except slightly higher scores in the conventional cohort on post-operative day 3. A multivariable linear mixed model showed ERAS to be associated with reduced morphine milligram equivalent use, while other variables such as BMI, age, reconstruction type, laterality, and anesthesia type were not. The limitation of this study include the retrospective design and the lack of patient-reported outcomes. To summarize, the adoption of the ERAS pathway in a large heterogeneous group of microsurgeons improved patient outcomes by reducing total opioid consumption, length of hospital stay, and incidence of postoperative complications. The type of anesthesia did not have an impact on the morphine milligram equivalent use. I would like to thank my mentors, Dr. Jesse Selber and Dr. Renee Largo, and thank you for listening.
All right, thank you. I'd like to open up session Q&A. You can submit via the chat function. Some of the questions that were submitted have already been answered directly. I'll start with the last presenter, Dr. Assad. Can you just explain to us why you think there was no reduction in the length of stay, still going from, it says 4.8 days to 4.6 days, despite all the reduction in opioid use?
Thank you. This is a great question. When we looked at the reason why patients were still in the hospital, the main reason was the surgeons wanted to check on the free flap. So they wanted to see if the flap was doing fine after surgery. And the second reason was the return of bowel function. So these were the two main reasons why there was no significant difference in length of hospital stay.
With the reduction in opioids, you'd expect a quicker return of bowel function. Do you think, are you doing anything specifically intraoperatively to address the pain in the breast region, separate from the abdominal region in terms of blocks, such as in some of the implant papers, because that may also increase postoperative pain?
So the ERAS group had liposomal bupivacaine for pain control during the operation, but we're not sure if that is the main reason why patients are not returning to normal bowel function after surgery.
But that was given in the abdominal donor site, not in the breast recipient site. There's still surgical pain in the breast region that has to be addressed separate. Just curious if you use any local regional anesthesia in the breast region.
No, we did not use regional anesthesia in the breast.
Okay. Let's see. Dr. Goldman, I think your presentation was very interesting. You had really great photo documentation. I think one of the questions, and you pointed out briefly, the effect of radiation on these patients postoperatively may impact the outcomes. I saw you had 4 patients. You showed 1. In the other patients, were there any significant loss of volume? And because obviously you may not know if a patient is going to be radiated ahead of time. And so what happens once you find they go down that pathway?
Thank you. Great question. Radiated patients are difficult. Every radiated patient had asymmetry compared to patients that weren't radiated, at least subjectively. So I think it's fair to say that every one of the radiated patients had more contraction and more asymmetry than the non-radiated patients. It's hard to really quantify how much fat retention they had. We didn't really look at that, but for sure they were asymmetric, and they had, radiated patients, it turns out, we haven't quantified this yet, but radiated patients require more fat graft sessions than non-radiated patients, as you might expect. And we're in the follow-up paper that we hope to publish next year. It'll turn out that they need almost twice the number of fat graft sessions as non-radiated patients, and they still have asymmetry. So that's why I said that the jury was still out if we were going to recommend it. The 2 of the 4 that were included in this series, in this consecutive case series, 2 of them were unexpected post-mastectomy radiated patients, so we didn't expect it. And we really try to talk radiated patients out of this technique. They're all offered deeps, they're all offered latissimus flaps. It's the patients that say that I want something, if this doesn't work, I'm gonna wear a prosthetic, and we offered it to them. But great question, thank you.
Thank you. Still looking at if the audience has any questions. We haven't had any new submissions, but I'd like to ask Ms. Kadakia about her series. You hypothesized that the lack of follow-up may have reduced the complications that were reported. Did you see poor follow-up in this patient population? And you said these patients were all cosmetic reductions. So I'm just curious, were these self-pay patients or also included insured patients? Because demographically, that would be different, perhaps, payer groups. Are you there, Ms. Kadakia? Please unmute if you are.
Yeah, are you able to hear me?
Yes.
Okay, awesome. Yeah, that's a great question. Unfortunately, the database that we use doesn't provide us with insurance type information. It also doesn't provide us with information on follow-up. We just have data in the 30-day post-op period. So it doesn't tell us which patients were lost to follow-up versus not. That's a limitation of the database.
Okay, thank you. I think Dr. Contralateral had a question. I don't know if he wants to pose that live.
That's right. I'm going to jump in real quick. I have a quick question for Dr. Singh. I thought it was a wonderful paper. And, you know, one of the things I love about plastic surgery is that we can be very unique in what we offer to patients. And so when a patient comes to me for a second opinion and I offer completely different things than they had heard before, I look at that as a matter of pride. That's typically not how oncologic surgery is supposed to work. If you go to a different radiation oncologist, you should get something similar and evidence-based. Do you know if there's, based on your work and others, do you know if there's any movement within breast surgery to standardize the indications for nipple-sparing mastectomy and have something so that patients are offered it, even if that's not the preference of the breast surgeon?
Dr. Contralateral, thank you so much for your question and your kind comments. I think you bring up a really valuable point. I am not entirely sure about the answer to that question, but I certainly think that it's worth exploring to see if we can standardize what we're offering patients, even from an oncologic standpoint. And I'm happy to follow up with you over email about that.
Thanks. Dr. Singh, also just, do you think that the things that you were measuring, such as age being a factor affecting access, may also be related to, well, let's say that age may be a surrogate for another factor such as breastosis, which may be increased in an elderly patient or an older patient, and for perhaps skin involvement or need for radiation in a patient with a higher stage, and that those are really the things that we're seeing rather than actual biases regarding the individual patient from a surgeon standpoint.
Yeah, absolutely, Dr. Smith. And the literature search that I did as a part of writing up the paper, we did find that, and this is in accordance with previous research. It's not just age that's acting as one of the factors or one of the disparities, but it is also given the fact that the breasts do become more ptotic and the skin is not always amenable to NSM. So what was interesting in this research was we found that the surgeon level factors were the most important predictors for nipple-sparing mastectomy.
Thank you. Dr. Lee, do you do a subareolar biopsy at the time of the delay, since you're there, to help gain information in terms of the need to potentially remove the nipple in those patients who may have some abnormalities?
Yeah, excellent question. I mean, this is another benefit of doing the nipple delay procedure, is that you get information about the subareolar biopsy to see whether or not it is worth it to continue on doing the NSM procedure. So we've had one patient in our cohort who did have a positive subareolar biopsy, in that case that was discovered upon the nipple delay procedure. And then in that case, the patient was notified of that. So another benefit of nipple delay, yeah.
Thank you. And one last question for Ms. Kadakia regarding racial disparities. The attendee asked, for the propensity matching paper, did you account for the fact that NSQIP reporting institutions change over the reporting years? This certainly can impact the total numbers overall. Increased numbers may not be just more patients having procedures.
That's a great point. We did not account for the number of institutions over the years, but we did account for the year itself to see if that was a variable that affected. And we kind of also matched the two groups for the years, and we use the year as a variable to match them as well. So hopefully that accounted for the changes in the number of institutions over the years.
I think just in the database, I think, well, they just may have more patients showing up in your database by year. So that may be hard to interpret, I guess, is the attendee's point. Okay, I think it's time to move on to the next session. I want to thank again all of our presenters. It was an excellent session, and thank you to our audience for participating.
Thank you so much, Dr. Smith, Dr. Song. Really appreciate your participation this morning. A great deal. So thank you. It was an excellent session. So we're going to move on. We're mostly on time. We're going to move on to the cosmetic session. And we're thrilled to have Lou Bucky and Alan Matarazzo moderate this session. And we appreciate them being here this morning. So I'm going to turn the program over to them. And thank you again.
Thank you, Brian. And my co-moderator, Dr. Bucky from Philadelphia. This begins session 3, the cosmetic section. And paper number 21 will be Perfecting the Profile, 3D printed surgical guide in obtaining ideal contour and rhinoplasty.
Hello, I'm Jillian Schreiber, and I will be presenting Perfecting the Profile, 3D printed surgical guides in obtaining ideal nasal contour and rhinoplasty. These are our disclosures. So virtual simulation is becoming increasingly common, particularly in rhinoplasty, and it is used during the consultation to help align the surgeon and patient aesthetic goals. However, this technology really offers much more than just simulation for consultation. Looking at virtual surgical planning, which is really becoming standard of care for surgery on the craniofacial skeleton, because of its ability to simulate operations before they're performed, and then to print 3D guides based off the simulation to help execute this plan. We aim to apply this for surgery on the soft tissues, including rhinoplasty. So this is an example of 3D printing that we are using for rhinoplasty. And here on the left is the patient's preoperative nose, and on the right is the simulated result. And how do we take this into the operating room with us? Well, with 3D printed models, as well as a guide that's actually placed on the patient's nose, shown in the center. So this is how the guide works. It's placed onto the nose, and it helps to determine the dorsal aesthetic as well as the tip position. So we aim to study the application of 3D printed surgical guides to help determine the dorsal height as well as to control nasal tip position during rhinoplasty. We performed a retrospective study of 17 patients undergoing primary rhinoplasty. All patients had virtual simulations performed in the preoperative period, as well as 3D printed surgical guides that were used intraoperatively. We studied the nose in thirds. So we looked at the bony dorsum, the cartilaginous dorsum, as well as the tip. And the tip was studied based on the rotation and the projection. So this is a representative patient who required reduction of her dorsum, as well as derotation of her nasal tip. Here is a 3D printed model of her simulated result, as well as the 3D printed surgical guide placed on the nose. And this is after reduction of her dorsal hump. But you can see that the nose requires tip projection as well as derotation based on this guide. On the left, the guide is placed, and while the tip is closer to the simulated result, it does not fit perfectly. And finally, on the right, after further modification, we were able to confirm that the tip was in an appropriate position. These are our patients, which ranged in age from 18 to 49 and included 15 open rhinoplasties and 2 closed rhinoplasties. And looking at position of the nasal tip of the simulated result versus our operative result using the tip guide, we were able to confirm that our results were within 1.2 millimeters in terms of tip projection and less than 1 millimeter in terms of tip rotation. Looking at the dorsum, projection was within 1 millimeter of the cartilaginous dorsum and 1.1 millimeters of the bony dorsum. This is a color map representation of this. So we overlaid the simulation with the operative result and had the computer calculate the difference in projection, represented by these colors. So in green, there's a difference of 1 millimeter positive, and red is 1 millimeter negative. We attribute the overall positive gain is edema, but you can see that the red is reduced by 1 millimeter. So all in all, the simulation and operative result are within 2 millimeters of each other. Looking at the spread of our patients, so the Z coordinate represents differences in tip rotation, and these were very close. This graph ranges from within 3 millimeters, and most patients are within really 1 millimeter of each other in terms of the simulation versus the operative result. And the tip rotation is similar within 1 to 2 millimeters. For the cartilaginous and bony dorsum, this graph represents that the simulation and the operative result were also very close to each other. And for most patients, this was within 1 millimeter. So in conclusion, virtual simulation is incredibly useful during the consultation to visualize the intended aesthetic result during rhinoplasty. However, this technology offers much more in terms of operative planning and execution by way of 3D printed models and surgical guides. And this really helps surgeons to translate the simulated result that was discussed in the consultation period into the operating room in order to ensure that their result is meeting those aesthetic goals that are defined preoperatively. And our findings support that using this 3D printed tip guides, we were able to achieve the simulation within a very small margin. Thank you.
Excellent. I assume the chairs would want us to do all the talks first and then have group questions. Is that right?
My name is Shanlin Chen, and
proceed. We have
layperson perceptions of surgical versus non-surgical rhinoplasty outcomes. I have no relevant disclosures. There's been a rising trend in non-surgical aesthetic procedures that are non-invasive or minimally invasive. Facelifts and rhinoplasties can now be done with injectables as opposed to traditional surgical techniques. This project looks specifically at the non-invasive liquid rhinoplasty, which uses filler injections to temporarily tweak nose shape for improved facial aesthetics and function. Previous studies have demonstrated that patients who undergo surgical rhinoplasty appear to casual observers as more attractive or more likable. Our goal was to determine how non-invasive rhinoplasty compares to surgical rhinoplasty in improving observer ratings of the following outcomes: attractiveness scores and personality traits. Personality traits were further broken down into approachability, femininity, financial wealthiness, kindness, success, both professional and social success, and self-esteem. This study was a Qualtrics survey distributed using Amazon MTurk's crowdsourcing platform. Participants were shown pairs of before and after images of publicly available photos. There are 3 types of images: surgical rhinoplasty, non-surgical rhinoplasty, and controls. For each pair, participants were asked to rate the change in a specific trait, for example, attractiveness, between the before and after image on a scale from -50 to 50. A total of 569 survey participants with a mean age of 40 years old, 60% female, completed the survey. Here, we see various outcome scores: attractiveness, personality traits for the invasive, non-invasive, and control images. The greater the score, or the closer to 50, the more increased the outcome after treatment. For the invasive group, we saw a net increase in outcome scores after rhinoplasty in all domains except for wealthiness. For the non-invasive group, there was a net increase in median score after liquid rhinoplasty for attractiveness and self-esteem only. Upon multivariate regression to characterize the association between treatment type and change in outcome scores, we saw that attractiveness and personality trait scores for invasive group increased to a greater extent compared to that of the non-invasive group. For example, when we're looking at attractiveness, the change in attractiveness between the after and the before image for the invasive group was 12.52 points more positive than that for the non-invasive group. This effect was statistically significant across all domains. Lastly, participants were shown this pro-con table and asked about their preference for either a surgical or a non-surgical rhinoplasty. 55% of participants preferred surgery, whilst 45% of participants preferred fillers. When participants were asked about their reason for choosing either surgical or non-surgical rhinoplasty, the most common reason for non-surgical rhinoplasty was shorter recovery time and lower costs. The most common reason for surgical rhinoplasty were permanent results. In conclusion, we have demonstrated that surgical rhinoplasty is associated with increased improvements in attractiveness and personality traits more so than the non-surgical rhinoplasty. From the layperson perspective, soft tissue fillers are not an equivalent means to achieving the same aesthetic outcomes as a surgical rhinoplasty. Additionally, we saw a mixed layperson preference for invasive versus non-invasive rhinoplasty. This study highlights the importance of patient education to further discuss layperson perspectives of either treatment. Thank you so much for allowing me to present my work today. I would like to acknowledge the following people: Dr. Yang, Dr. Steinberg, Dr. Redette, Dr. Jenny, and Maya Busi for their significant contributions and support in this project. Thank you so much, and I look forward to further discussion today.
The next paper will be the Ideal Nipple Areola Complex, a study in aesthetic preferences.
Hello, everyone. My name is Pooja, and I'm an MS4 at Johns Hopkins. Today, I will be presenting our work on the Ideal Nipple Areola Complex, or NAC. The authors have no disclosures. Nipple reconstruction involves deliberate nipple areola complex placement based on aesthetic norms that are derived from native breasts. While prior literature has investigated ideal nipple positioning, no one has comprehensively investigated NAC aesthetics in terms of position, size, and color. Furthermore, more current guidelines with regards to NAC aesthetics that reflect the increasingly diverse population of women undergoing breast reconstruction are needed. This led to our study. The objective of the study was to characterize current aesthetic preferences in the United States with regards to the female NAC. The surgeon is often required to make important decisions about NAC aesthetics during the reconstructive process. Thus, we also surveyed plastic surgeons' NAC preferences. In doing so, we ultimately hoped to inform aesthetic recommendations for female NAC reconstruction. We conducted a cross-sectional investigation of public and surgeon preferences. Participants from the general public were recruited through Amazon Mechanical Turk, an online crowdsourcing platform. Surgeons were recruited through the American Council of Academic Plastic Surgeons listserv. In total, we had 845 respondents from the general public and 52 surgeons. Participants were surveyed on NAC preferences with regards to size, color, and position on the breast mound. The survey was composed of post-operative patient frontal view photos of patients undergoing breast reduction. Patients across multiple Fitzpatrick skin tones were included. Survey images were generated using Adobe Photoshop. The base width of the breast, measured from the mid-sternal line to the anterior axillary line, was used to guide variations in nipple areola complex diameter in survey images. These were correlated to standard nipple sizers to generate clinically relevant results. The nipple position was also varied. Along the horizontal axis of the breast mound, the nipple areola complex was positioned either medially or laterally to the midline of the breast. Along the vertical axis of the breast mound, the nipple areola complex was varied along the vertical arc of the breast. The upper pole to lower pole ratio was used to demarcate vertical positions as displayed here. Overall, position preferences varied by shape of the breast mound, respondent gender, and respondent age. Across all comers, respondents preferred NACs that were lateralized to the midline on the horizontal axis and at the 50-50 mark on the vertical axis. However, with teardrop-shaped breasts, While respondents still preferred lateralized positions on the horizontal axis, they preferred more inferior placement on the vertical axis at the 60-40 mark. Across breast shapes, females had a strong preference for NACs that were lateral to midline on the horizontal axis and at the 50-50 point vertically, while male respondents had an equal preference for NACs at 50-50 vertically or NACs that were more superior at the 40-60 mark. We analyzed age as a continuous variable. Across breast shapes and gender, older age increased odds of preferring NACs that were lateralized to midline on the horizontal axis, but more inferior on the vertical axis at the 60-40 mark. Size preferences varied by shape of the breast mound and respondent gender. Surgeons and the public preferences also were found to vary. Overall, respondents preferred a 42 millimeter diameter NAC. However, for teardrop-shaped breasts, there was a greater preference for 45 millimeter NAC diameters. Across breast shapes, while female respondents had a strong preference for the 45 millimeter NAC diameter, male respondents were more varied in their preference and were more evenly distributed amongst smaller NAC diameters. Interestingly, plastic surgeons had a stronger preference for larger NAC diameters than respondents from the general public. Color preferences were found to vary by the skin tone of the underlying breast mound, and surgeon and public preferences were also found to vary. Overall, participants preferred an NAC that was of the same tone as the underlying breast. However, for darker breast skin tones, participants had a less strong preference for lighter colored NACs and actually tended to prefer NACs that were darker. The general public had a strong preference for lighter tones, while surgeons were more evenly distributed into the darker tones as well. Across nipple size, position, and color, we found no regional differences in NAC aesthetic preferences. This suggests that our study results may be generalizable. Overall, we found that NAC preferences varied by multiple demographic factors, highlighting the highly individualized nature of nipple reconstruction. We also found that surgeons and general public preferences differed with regards to certain aesthetic preferences. Recognition of such differences can help providers manage their own biases and can help surgeons better understand and manage patient expectations during the NAC reconstruction process. This study has multiple limitations, including its cross-sectional study design, as well as its survey methodology. However, we did assess survey validity and reliability and conducted pre-testing in order to maximize the quality of responses. Thank you so much to the Northeastern Society of Plastic Surgeons for giving me the opportunity to share our work today.
Thank you. Our next paper is number 24, Estimated National and Regional Impact of COVID-19.
Thank you for this opportunity to present our work. We have no financial disclosures. The first cases of COVID-19 were identified last December in Wuhan, China. Less than 1 month later, the first U.S. case was identified in Washington State. By early March, the WHO declared a global pandemic. By March 19th, CMS, ASPS, and ASAPS released guidance advising an immediate suspension of elective surgeries. The crisis subsequently grew, and New York became an early epicenter of the pandemic. This project was devised in late March as an attempt to anticipate what impact the pandemic would have on elective aesthetic case volume in the United States. Since this project began, COVID case numbers have decreased, and elective surgical cases have since resumed. However, throughout the United States, there are still thousands of new COVID cases daily, and estimates of the U.S. death toll are approaching 200,000. We utilize data from the American Society of Plastic Surgeons in order to anticipate the impact of the pandemic on elective cases. These data include case volumes of the top 5 most commonly performed cosmetic procedures in 2018. These figures are provided on a regional basis with the 5 regions depicted as different colors in this map. Region 1 includes the northeastern United States. Data on the anticipated impact of the pandemic were derived from the Institute for Health Metrics and Evaluation at the University of Washington. This model depicts, by state, anticipated hospital bed, ICU bed, and ventilator requirements on a daily basis. Of note, estimates discussed herein rely on data derived from the model as of March 27th. We chose to estimate the total number of OR days lost as the duration from March 19th to when patients would no longer require invasive ventilation. This was chosen as there was an early concern for a national shortage of ventilators, as well as because it was thought this metric most acutely reflected the greatest burden on the healthcare system. The first results we tabulated were the mean and range for the number of days from March 19th to the resolution of ventilator requirements for every state. We then took the state-specific data and calculated regional values based on the state groupings used by ASPS. Region 1, the northeastern United States, was anticipated to have the shortest duration of OR suspension. This is because the height of the crisis in this region occurred early and therefore was anticipated to resolve earlier as compared to states further west. Regions in the South and West were predicted to have a peak of cases later on with a correspondingly later resolution. These anticipated durations were then applied to the average daily case volume by region. The top 5 most common procedures in each region vary, as do the total number of cases performed. Region 5 was predicted to have the greatest loss in overall case volume as a consequence of both having a greater estimated duration of OR closure as well as a greater pre-pandemic daily case volume. In the Northeastern region, despite having the fewest number of anticipated OR days lost, there is not the fewest number of anticipated cases lost. This is due to there being a greater number of daily cases performed historically in this region compared to others. We next applied national average surgeon's fees by procedures to the anticipated cases lost. We acknowledge that surgeon's fees do not capture the entire economic loss of these cases. We did not include economic estimates of the facility fee, the anesthesia fee, or any materials used. The national loss of surgeon's fees based on these predictions is approximately $1.2 billion US, representing a 20% loss compared to 2018. We continue to experience an ongoing crisis. The pandemic is not yet over, but life is starting to regain some semblance of normalcy. Our model predicts an approximate 20% economic loss for surgeon's fees alone compared to 2018 due to closures from the pandemic. However, this model may be overestimating the impact of the crisis. Most states resumed surgeries far earlier than our model anticipated. Some of the states that reopened while COVID cases were still high had to resuspend elective cases, such as in Texas. Other states resumed surgeries on a graded basis, and as such, elective cosmetic cases are occurring at a frequency that is less than what was historically experienced. Further, new requirements for COVID testing have changed the manner with which cases can be scheduled and booked. Conversely, some cosmetic surgeons have noted an increase in patients seeking surgery as working from home provides a unique opportunity to recover from surgery inconspicuously. Some patients may now prefer to undergo surgery in an office-based setting because it is seen as preferable and safer to going to the hospital. The cumulative effects of these variables remain unknown. Despite these uncertainties, this model informs our understanding of the reliability of predictive models of the pandemic and how the United States healthcare system may respond to future crises. This investigation helps elucidate which metrics of an international health crisis inform a return to normal activities, and where areas of uncertainty may exist and prospective estimation of similar scenarios in the future. Thank you for your time.
Excellent papers. I think we're at a question and answer phase right now, so if we could open up.
Good morning. My name is Jolyn Chen, and today I will be discussing a systematic review on the implementation and educational value of resident aesthetic clinics. I have no relevant disclosures. Aesthetic surgery training is a core requirement for any plastic surgery residency. Competency in the top 5 cosmetic procedures today, including breast augmentation, liposuction, eyelid surgery, nose reshaping, and facelifts, is required for training completion. One method to meet aesthetic surgery training requirements is through the resident aesthetic clinic, which allows residents to see and operate on patients under attending supervision. As most institutions have adopted resident aesthetic clinics, a variety of clinic structures now exist. Thus, a critical challenge moving forward is identifying best practices to optimize trainee education. While previous reviews have demonstrated successful resident aesthetic clinic outcomes, we wanted to conduct a programmatic evaluation to characterize clinic practice patterns and educational successes of resident aesthetic clinics across the country. We conducted a systematic literature search on April 21st, 2020. Out of a total of 1,616 papers identified via database search, we included 10 in our systematic review, 6 of which were single-site studies and 4 of which were multi-site studies. Here, we denote the 5 clinics that were included in the systematic review. For each clinic, we documented the number of patients undergoing procedures and the number of procedures recorded over time for the duration of each paper's chart review. All clinics were clustered in the Midwest and Northeastern United States. Clinic locations encompass a variety of city populations, ranging from 1.5 million in Philadelphia to 250,000 in Winston-Salem. The number of residents in clinic was distributed evenly, with class sizes ranging from 2 to 6 residents a year. Looking at the distribution of volume across institutions, there is no correlation between city size and clinic volumes. The annual patient volume undergoing surgery ranged from 22 to 68 patients a year. The annual cases performed range from 35 to 81 cases a year, with the majority being breast and abdomen cases, meaning the most common cosmetic surgeries performed in the United States per data from the American Society of Plastic Surgeons. Since the patient volume was lower than the procedural volume at all institutions, patients often underwent multiple surgeries at the same clinic. In terms of clinic structure, residents had a longitudinal exposure clinic, spending 1 to 2 years and half to a full day a week in clinic. Residents are the first point of patient contact for all clinics. Of note, at Wake Forest, co-residents would interview new patients together and converse about the patient plan prior to consulting with the attending. For operating room autonomy, most clinics reported that residents were the primary operators and attendings were the assistants. At Washington University of St. Louis, residents and attendings were described as a team. A variety of strategies were employed to evaluate resident plans. This included single supervising attendings in clinic, patients reevaluated in an attendings clinic, weekly indications conferences, and aesthetic grand rounds held by the chief resident at the end of their rotation. Patient recruitment primarily occurred through word of mouth. Some clinics also used direct patient referral from other surgeons, often due to patient financial limitations. All clinics had a full-time academic faculty as supervising attendings. Additionally, adjunct faculty members supervised at the University of Pennsylvania and community plastic surgeons at Harvard University. Residents at all 3 of these clinics felt that clinics positively contributed to their education and felt that clinic was important in their choice of residency. Residents at the majority of these clinics also did not pursue cosmetic fellowships, suggesting that good clinic training decreased the need for fellowship. In conclusion, we have demonstrated that critical clinic features include resident autonomy, longitudinal experiences, resident feedback via conference or single attending feedback, patient recruitment via word of mouth, faculty member staff clinics, and strong clinics that decrease the need for fellowship. Thank you so much for allowing me to present my research today. I would like to acknowledge Dr. Broderick, Professor Cooney, Erica Lee, and Lean L. Etter for their contributions and support. Thank you, and I look forward to further discussion later today.
Let's open it up for questions. We have one question from the audience on the last paper. Has there been any mention how the costs of complications are affected in the resident clinic? In other words, how do they handle complications and costs? Was there any mention made of that?
Yeah, so in our literature search, we did find that there were no differences between resident clinics and attending clinics of costs and complications, but we didn't really come across any specific methods that they mentioned how exactly they handled cost of complications. There were low rates of complications, but nothing specific on how they handled the cost. Interestingly, the majority of these clinics are fee for service, and oftentimes the cost of certain procedures at these resident clinics is cheaper than the attending clinics. And so that's interesting to note too.
Do you have an opinion as to why there was a propensity towards abdomen and breast surgery as opposed to the face area?
Yeah, that's a really great question. I think one common thought through all of these papers that we read was that oftentimes facial procedures weren't introduced into a resident's training until later on in their training. And so oftentimes these cases were more complicated and then not introduced later on. It made it potentially more likely that residents who were introduced to breast cases and abdomen cases earlier on in their training ended up being more confident as well as more competent in those breast and abdomen procedures.
I would strongly encourage, since we have a high volume of residents on the phone, to get comfortable in the head and neck area. There's a saying that you're as good as your training. And it's an arena that I think my colleague, Dr. Bucky, will agree that we're seeing plastic surgeons doing less of in the future. So that's something that you really need to get comfortable with. You only get one shot at it when you go into practice. You don't get to do 3 noses that don't turn out correctly. Are there any other questions from the audience? Dr. Bucky?
Yes, I thought the talks were all excellent, by the way, and I'm just going to start from the top down and we'll keep going. But Dr. Schreiber, excellent presentation. I've seen Dr. Tepper's presentation as well. I have 2 quick questions. One, tell me about the FDA issues of a device that's used both for communication and planning. And then the second more important question to me is, while you're achieving intraoperative accuracy, tell me about, this will be a wonderful device to describe what happens over a long period of time. In other words, how accurate is meeting your goal intraoperatively versus how they all look long-term, which goes along with Dr. Matarasso's prescription of getting comfortable with facial procedures.
Right. So for the first question, I think a really big issue, and one of the issues that this project tries to address, we're simulating for patients on a computer changes to their nose and showing them visually a result that is not a surgical result, it's a simulated result. And so while it may be something that they like and want to achieve, the question of, is this possible surgically, is a whole nother issue. And so I think it's really important that not only you have that discussion with the patient preoperatively, but also to use something like this technology, because what are we, if we're doing that with our patient, how are we making sure that we are taking that with us and trying to honor that in the operating room? And so I think that's a big issue. And with the FDA, I think addressing that is important. The second question, so that's something we thought a lot about in terms of long-term results. So edema is a big issue in rhinoplasty, and we had a question of, should we account for edema intraoperatively with making the guide, meaning should the guide be larger to account for the edema? Should we overshoot, for example, in terms of tip projection, knowing that edema will come down and then will meet that simulation? So we're doing another study actually using 3D technology to help to understand edema in the postoperative period of the nasal tip. So knowing that information, for example, knowing that the tip will deproject by a certain amount could help us to account for that in making these surgical guides.
There are similar papers in the breast that have described changes in the breast over time using 3D imaging. Out of New York and other places. I would suggest doing that, but you have a device now that can tell not just edema, but stability of rhinoplasty over a long period of time based on what happens in the OR versus a longer period of time. And because you're young and intelligent, I highly encourage you to look at long-term results using this device. It would be good.
I agree, thank you.
Alan, I don't have access to the other questions, but we can keep going. I have a question.
Keep going. There's nothing on the board.
Okay. Regarding the MTurk study, or the analysis of layperson and perceptions about non-surgical rhinoplasty outcomes, can you tell us a little bit more about how accurate the Amazon MTurk group studies are, or group evaluations?
Yep, definitely. That's a great question. So a lot of papers have been published in the literature saying that the MTurk population is in fact comparable to the layperson population, as well as the population of people who are interested in pursuing plastic surgery procedures. Additionally, there have been studies saying that the MTurk population, they are very, very efficient survey takers, but also a lot of their assessments of different personality traits is comparable to the layperson.
Have there been studies using MTurk to provide clinical studies for such things as FDA approval or claims or anything else like that? Are you aware of?
I'm personally not aware of any studies of MTurkers providing any sort of feedback on FDA approval, but that's definitely something interesting to look into.
Okay.
Can I ask you, did you consider using the patient as their own control? Because the filler rhinoplasties have been, for many of us, associated more with secondary. And when you look at public perceptions of it, taking a preoperative patient, doing it non-surgically, letting that settle down, and then going back and doing it surgically, and then crowdsourcing it.
Yep, definitely. So we included 2 control images in our survey, and those were patients who had not undergone any sort of rhinoplasty procedure, either invasive or non-invasive. So those patients were considered their own control.
Okay.
And Dr. Chen, I've got a question from the audience and one for myself. It says, they don't think that you can extrapolate that cosmetic clinic was the reason residents did not do a cosmetic fellowship. I'll add to that. I think there are many reasons why people choose to do fellowships. And it's not necessarily always an indication of absence of competency. There are obviously variables like what makes you more appealing in the community once you leave training, how to gain research expertise and other things like that. I'd like to know your thoughts regarding that, because obviously you made that an indication of competency, but I'm going to challenge that, and so did one of the other people in the audience.
Definitely. We certainly agree that, it's not possible to extrapolate that, just having a cosmetic clinic decreases the chance of residents wanting to go to clinic. But what we did see was that out of 3 of the single site studies with strong resident aesthetic clinics and clinics that residents felt had really improved their understanding of aesthetic training, these clinics tended to not have any residents want to pursue additional cosmetic fellowship training. So there was an association, but we agree we can't, infer any sort of causality.
Can you provide me 3 reasons why those same programs would not have people go to fellowships that had nothing to do with their training or nothing with their competency level?
Definitely. I mean, it could just be interest. I think that's one important reason, whether or not people are interested in fellowship. It could also be what people are interested in doing in the future, as well as, cost of doing fellowship and wanting to seek additional training.
Yeah, I mean, it could be that it was a negative experience even, right? That the clinic was negative and those patients those residents don't want to be doing that. I'm not saying that's the case at all, but I think that putting that as a variable was probably the weakest of a otherwise very good study.
3 quick questions, if I may. For paper 1, the cost of the 3D imaging.
So the cost right now is around $200, but as this technology, 3D technology is becoming more and more accepted, not only in plastic surgery, but in our civilization in general. So I think, as the technology becomes more accessible, the cost will come down, but that's the cost.
Paper number 4 from Northwell Dana. This is a little peripheral to your study, but there's been some concern raised about how long the increased risk for thrombosis lingers after COVID. So we bring them in with a negative COVID test, but are they still at risk if they've had COVID for increased thrombosis? It's not directly related to paper, but do you have any thoughts on that?
Thank you for that question, Dr. Matarazzo. Yes, at this point, we are unsure how long the increased risk of venous thrombosis exists after one has COVID and recovers. And we are not actually routinely in our hospital system testing patients for antibodies to assess whether they may be at an increased risk. I anecdotally know that some surgeons who have operated on patients with history of COVID have been more concerned about an increased risk of thrombosis, and that has encouraged them to use venothrombo prophylaxis, such as continuing the patient on Lovenox. However, at this point, I think, unfortunately, it's too early for us to have any certainty with regards to how long that duration of increased risk may persist.
There's one final question from the audience. Based on, this is for paper number 5, based on your research, do you have any thoughts on the best model for an aesthetic clinic?
Yeah, that's a great question. I think ultimately we saw a variety of different clinic structures, different ways that clinics are implemented. And so I think the bottom line of the paper is that regardless of how one conducts and implements different aspects of the resident clinic, ultimately we do see improved educational outcomes and improved resident perception of clinic as positively impacting their education. So ultimately, regardless of how clinics are carried out, there are a variety of different structures, but there wasn't a single structure that was more beneficial for educational value than another.
So thank you. Speaking for Dr. Matarazzo and I, these were great papers and we could go on for a long time, but the last thing we want to do is keep Dr. Wu and Dr. Baker waiting on their end. So congratulations to wonderful papers. And I want to take 1 second and congratulate Dr. Glatt and Conchwala and the rest of the Northeastern Society to not be deterred, to keep a great society going in difficult times. So thank you all very, very much.
Yes, thank you.
Well, thank you, Dr. Bucky and Dr. Matarazzo. Before I introduce Drs. Baker and Wu, I wanted to just take a second to just remark on how wonderful it is that we have almost 125 people attending this right now, in what would be a morning session. And typically at a normal meeting, we would be in a break at some point and chatting with one another and giving comments to all the good presenters that have presented today. And I want you to channel that energy into the question and answer in the chat function, quite honestly, because it doesn't have to be a question. It could be a comment in support. That's the purpose of our society in large measure, is to be able to give feedback to research that's in its nascency so that it can get better into its publication stage. So thank you for all those who have commented and all the questions that have been asked, and please continue to do that. Driving that engagement is what's going to allow us to grow as a society. I also have the distinct pleasure of knowing who the winners are of the residence competition, but Dr. Mackay is going to be presenting that in about a half an hour. So without further ado, Drs. Wu and Baker for the last session of this morning. Thank you.
Welcome. This is session 4, practice. We're going to get started with presentation number 26, Is There a Gap? Examining gender disparities in industry payments and their geographic distribution amongst plastic surgeons.
Hello, everyone. Thank you for allowing us to present our research today. My name is Sammy Othman. I'm a medical student from the Drexel University College of Medicine, discussing our project entitled, Is There a Gap? Examining gender disparities in industry payments and their geographic distribution amongst plastic surgeons. To start, we have no disclosures. And for some background, as of last year, 2019, over 50% of US medical students are females. Unfortunately, females are continually underrepresented in surgery, and this comes in the form of compensation disparities, even after controlling for education background, specialty, board certification, and location. Industry payments represent one means to further a physician's career and narrow the gap in gender disparities. Unfortunately, previous research in other specialties have found that gender disparities exist in the setting of industry payments. These include studies in radiation oncology, ophthalmology, ENT, including one recent study in plastic surgery that found a difference over a 1-year period. In our study, we sought to examine if these disparities exist in a multi-year setting, and if so, where amongst payment categories these differences may exist, and if geographical location had any implication. We hypothesized based on previous research that we would find gender disparities amongst females and males in plastic surgery. We performed our study by using the Center for Medicare and Medicaid Open Payments database, which helped us identify potential plastic surgeons, as well as pull payment information, including subcategories. We then used Google and the American Society of Plastic Surgeons database to further include and exclude specialists and plastic surgeons for this study and find gender information. Our primary outcome was if there were any differences based on gender amongst plastic surgeons, and our secondary outcomes were if differences existed, by which payment category, and if location was impactful. We used univariate, multivariate, and sensitivity analyses for statistical testing where appropriate. We found that overall $120 million were paid to 1,533 plastic surgeons over this 5-year time period. After excluding for personal costs and travel, we found that this number dwindled to $99 million. And after removing the top 1% of outliers, we found a total of $44 million paid to 1,518 US plastic surgeons. In total, we found that $3 million were paid to 203 females, while $40 million were paid to 1,315 male surgeons. When broken down by per male and per per female basis, we found an almost 2-to-1 ratio where males made $30,000 compared to just $16,000 for females. We then examined this difference statistically based on median payment. We found that overall, males made a significantly greater amount of money compared to females, and specifically in the honoraria category, where males were paid a significantly greater amount than females. Other sub-analyses and payment categories found no differences between genders, and overall, the annualized overall payments showed that there was a significant difference in the amount of money that males made compared to females, where again, males were paid a significantly greater amount of money. Geographically, we found that just 38 of 50 states had females that qualified for this study. The states colored in black were where females were not qualified for this study. And overall, we found that even after controlling for state-level variations, we found that males again made significantly more money than females in the form of $3,473 compared to females. The limitations with this study are there are inherent inaccuracies within the CMS database that have been well detailed before. There's a lack of granularity, including practice setting in terms of private versus academic practice, academic appointments, experience levels, and provider subspecialties amongst plastic surgeons. There's selection bias, and we were unable to discern, in some cases, cisgender versus transgender surgeons based on our informal Google searches. In conclusion, we found that overall, females made significantly less money even after controlling for state-level variation compared to their male counterparts, and this was especially magnified in the setting of honoraria payments, where a significantly greater amount of money was paid to males compared to females. Thank you for allowing us to present our research today.
Thank you very much for that thought-provoking presentation. This is number 27, Leadership Ambitions in Plastic Surgery. Do women and men want the same thing?
Good morning, I'm Farah Saig from Mount Sinai in New York, and I'll be talking about differences in career aspirations among women and men in plastic surgery. We know that there's a disproportionately low number of women in top leadership positions in medicine and specifically in plastic surgery. As of 2019, women comprised nearly half of medical school graduates and 41% of faculty positions across the country. However, women only make up 16% of practicing plastic surgeons registered with the ASPS and 18% of plastic surgery faculty positions. So we wanted to examine the potential differences between genders and their desire for advancement to positions of higher leadership within plastic surgery. A survey exploring career aspirations was circulated amongst plastic surgeons, both female and male. A propensity score matching algorithm was then used to generate gender cohorts matched by age, race, and whether they worked in academia or private practice. The relationships between gender and various desires for roles of higher leadership, academic rank, and greater responsibility were then analyzed. The survey initially garnered 360 respondents, of which there was an extremely disproportionate percentage of male respondents. After propensity score matching to correct for this disparity, each gender cohort had 56 respondents. Most of the matched surgeons had a current role in private practice, and there was no statistically significant differences between the two groups in current roles of administrative or leadership positions. Our results showed that males reported a higher desire to occupy administrative or leadership positions compared to females. The male cohort also reported a higher desire for greater career responsibility and advancement to a higher academic rank. Of note, none of these reached statistical significance. In order to investigate the potential causes of these differences, we asked about specific barriers to career advancement. The free text responses are arranged in word clouds here, where the size of the word signifies the frequency with which it appeared in the responses. On the left, we see that men reported hospital politics and administrators as their major perceived barrier to career advancement. On the other hand, the most common response from the female cohort was sexism. While our results did not reach statistical significance, the trends of females reporting less desires for leadership roles have prompted us to continue this investigation on a larger scale. Future efforts should concentrate on addressing sexism and establishing mentorship as a pathway to increasing female representation in plastic surgery leadership positions. Thank you for your attention, and I hope that we're able to come back to you with our larger scale results in the near future.
Thank you very much. Looking forward to that. This is presentation number 28, the use of Instagram by plastic surgery journals.
Hello everyone, my name is Pooja and I'm an MS4 at Johns Hopkins. Today I will be presenting our work on Instagram and academic plastic surgery. The authors have no relevant disclosures. Instagram is a visual platform with a tighter focus on content. Its scrolling interface prompts instantaneous engagement and reactions. In fact, it has higher engagement per post than Facebook, and it is the only growing social network in America. While plastic surgery journals have been using social media platforms such as Facebook over the past decade, Instagram has only recently gained traction in academic plastic surgery. In fact, in the last 5 years, there has been an exponential rise in the number of plastic surgery journals using the social media platform. The COVID-19 pandemic has accelerated this trend of using Instagram in an academic context, as plastic surgery academic societies have also turned to Instagram to disseminate research. Plastic surgery is a field especially suited to Instagram given its highly visual content. In fact, journals are using Instagram to publicize articles through visual abstracts, video clips, and Instagram live videos. Instagram in plastic surgery has both merits and limitations. Instagram presents research in a very easily digestible, captivating visual format. Furthermore, Instagram Live can connect authors and readers, and video clips allow readers to engage with material in ways that were not previously possible. However, social media carries a risk of bias. Prior literature in other social media platforms has demonstrated that the greater social media popularity does not always translate to higher levels of clinical evidence. Thus, there is a need to investigate the utility of Instagram as an e-learning tool in plastic surgery. Our study objectives were threefold. First, we wanted to characterize the use of Instagram by plastic surgery journals. Then, we wanted to determine the relative utility of Instagram in communicating and disseminating plastic surgery research. Last, we wanted to create a series of best practices for plastic surgeons interfacing with academic research on Instagram. We analyzed 4 journals with Instagram profiles. All original articles published in 2019 from these journals were extracted. We compared qualities of those that were posted on Instagram versus those that were not. Among those posted on Instagram, we also evaluated post content and post engagement. Between articles posted on Instagram versus those that were not, there were some significant differences in content. Review articles were less likely to be shared on Instagram, while clinical studies were significantly more likely to be posted. However, the topic of articles shared on Instagram did not significantly differ from those that were not shared. Overall, articles posted on Instagram were significantly less likely to be from international study teams and were significantly less likely to have female corresponding authors. However, articles posted on Instagram had significantly greater visibility in terms of full text views and article downloads. Among articles that were posted on Instagram, there were 3 main formats by which they were shared. The first was to post pictures of the actual abstract. The second was to use a visual abstract, and the third was to use a short video clip. Interestingly, actual abstracts and visual abstracts received similar post engagement in terms of likes, while videos were less popular. This may reflect the type of content users typically look for on Instagram. Given its scrollable interface, people may not stay on video posts long enough to watch the entire video. Visual abstracts are often limited in the amount of information they present compared to an actual abstract. Thus, the fact that visual and regular abstracts had similar likes suggested that people may not be using Instagram to get an in-depth picture of a study, and are rather just using Instagram to learn about new topics and areas of research in the field. However, further study of surgeons' perspectives is needed to better optimize visual presentation of information. In terms of who was engaging with the posts, both likes and comments were mostly from accounts affiliated with plastic surgery clinics, academic programs, or individual surgeons. Instagram provided substantially greater post visibility compared to other social media platforms. In fact, the same post on Twitter was liked 22 times and retweeted 12 times, received no likes on Facebook, but received 204 likes on Instagram. Overall, we found Instagram to be an important social media platform in academic plastic surgery. Advertising on journal Instagram pages improves article visibility for authors. Visual abstracts and regular abstracts fared similarly well in terms of post-engagement, so extra fees for visual abstracts may have limited value. For readers, Instagram posts by plastic surgery journals was largely representative of the published literature. Thus, Instagram could help readers discover academic content, thereby supplementing more traditional email and RSS feeds. However, it is important for readers to avoid confirmation bias. It's important for readers to follow up on the actual papers in order to gauge study merits for themselves. This study had a cross-sectional design and was therefore limited in terms of external validity and our understanding of longitudinal impacts. Additionally, there was a potential for misclassification bias of author and viewer profiles on Instagram. Lastly, study analyses may have been impacted by external factors. For example, the author's social network may have impacted post-engagement more so than the actual content itself. Thank you so much to the Northeastern Society of Plastic Surgeons for giving me the opportunity to present our work today. I'd also like to thank my mentors, Dr. Justin Sachs and Dr. Kristen Broderick, as well as my study team. Thank you so much.
Thank you very much. Sounds like a growing and important tool. This is presentation number 29, Telemedicine in the Wake of COVID-19 Global Pandemic, Increasing Access to Surgical Care for Disadvantaged Patients.
Hello, my name is Paige Decker. I am a research fellow at MedStar Georgetown University Hospital, and I'm excited to present our team's work investigating the impact of telemedicine on access to surgical care for disadvantaged patients. Prior to COVID, the growth of telemedicine was slow and fragmented, in large part due to obstacles in reimbursement and licensure. COVID brought with it improvements in many of these barriers, as well as an acute need to reduce unnecessary exposure to the virus with in-person visits. This allowed for a major expansion in the use of telemedicine. Within the MedStar system, for example, approximately 240 patients were seen via e-visit in February, and this number jumped to approximately 11,000 between March 13th and April 16th. We were interested specifically in how this acute expansion in the use of telemedicine might impact access to surgical care for disadvantaged patients. We performed a retrospective review on all patients with clinic appointments with 5 providers in the plastic and reconstructive surgery department between March 2nd and April 10th. We wanted to capture patients who were seen both before and after the expansion of telemedicine, so we chose March 23rd as our anchor date, as this marked the beginning of a multi-phase expansion of MedStar's telehealth platform. In addition to collecting basic patient demographics, we extrapolated several variables based on the location of each patient's residence, including an urban-rural designation, median income, and social vulnerability index, or SVI, which refers to the socioeconomic and demographic characteristics of a community that impact its resilience when faced with external stressors to health, like a global pandemic. A census tract's overall SVI is based on 15 variables that fall into one of 4 categories, which are shown in the larger boxes in the image to the right. The composite of data points captured in the SVI make it a good measure of disadvantaged status. The primary outcome of our study was whether or not a patient missed their appointment, which we called no-show versus show. During the study period, 506 patients were seen prior to the lockdown and 278 were seen after, for a 45% decline in overall outpatient visits. Video visits went from comprising less than 1% to over 26% of patient visits, and an increase of similar magnitude was observed for phone visits. We found that the mean SVI for both new and established patients increased after the lockdown. We also found that patients with a higher SVI, or those who lived in less resilient communities, were more likely to have a no-show in-person appointment prior to the lockdown. There was no longer a significant difference in SVI between no-shows and shows after the lockdown. Further investigation of this finding with multivariate regression modeling showed that before the lockdown, every 0.1 increase in SVI resulted in 1.32 greater odds of loss to follow-up. Again, this association no longer held true after the lockdown. Our results suggest that the dramatic increase in the use of video and phone visits that occurred in the wake of the COVID pandemic led to a reduction in disparity and enhanced access to care in the studied population. In addition to increased access, there are several other salient benefits to telemedicine that have been discussed in the literature. First, telemedicine has been well received by patients. One study investigating the use of telemedicine with plastic surgery patients in a rural underserved setting found that over 96% of patients reported that they would use telehealth again. Telemedicine has also been shown to have benefits on patient outcomes. A study examining the utilization of telemedicine by a wound specialist in conjunction with home health nurses found improved healing rates and fewer home health visits and hospitalizations after the implementation of telehealth. Lastly, when used correctly, telemedicine has the potential to improve cost and efficiency in a variety of specialties. There is still much to be done in order for meaningful and lasting adoption of telemedicine to take hold. We have to devise creative and easy-to-use platforms for patients who have limited access and/or understanding of technology while still maintaining HIPAA compliance. Improvements must also be made to picture and video quality, and we need to reduce the frequency of technological issues that can occur during visits. In addition to contributing to patient and provider frustration, these kinds of difficulties can also lead to delayed and/or misdiagnoses. And lastly, the temporary changes to reimbursement schemes and regulatory flexibility with respect to licensure that was seen in the wake of COVID must be broadened and preserved beyond the current pandemic. By using COVID as a singular time point that marked the beginning of a drastic expansion of telemedicine, we were able to find that this acute shift in healthcare delivery also led to a reduction in disparity and enhanced access to care in the studied population. Our findings highlight the importance of continued efforts to improve upon current telehealth platforms, as well as efforts to expand adoption and utilization of telehealth. I'd like to thank the Northeastern Society of Plastic Surgeons for the opportunity to present today. I look forward to answering any questions during the discussion.
Thank you very much. And the last presentation for this session, decreased optic disc cup volume with increased intracranial pressure.
Good afternoon. My name is Duncan Mackay. Today I will be talking about spectral domain optical coherence tomography and measurements of the optic nerve head as a non-invasive way to measure increased intracranial pressure in patients with craniosynostosis. We have no disclosures. The treatment of craniosynostosis is guided by both the frequent presence of elevated intracranial pressure and its neurodevelopmental consequences, as well as improving aesthetic outcomes. Currently, measures of elevated intracranial pressure either lack adequate sensitivity in the case of fundoscopy for papilledema, or entail an elevated risk profile, as is the case with direct measurement of ICP. The development of a measurement that is both sensitive and specific, as well as non-invasive, would be an ideal way to help guide the treatment plan and timing of surgical intervention for children with craniosynostosis. Recent work by Dr. Swanson, utilizing non-invasive spectral domain optical coherence tomography, or OCT, has identified changes in the peripapillary retinal structure with increasing intracranial pressure in cohorts of patients with craniosynostosis. They found two measurements of the three-dimensional disc parameter of OCT, maximal retinal thickness and maximal anterior projection, and one measurement of the optic nerve head parameter of OCT, the thickness of the retinal nerve fiber layer, to create cutoff measurements that would predict elevated pressure, yielding a sensitivity of 80% and a specificity of 91%. In the ophthalmology literature, changes in OCT measurements of the optic nerve head protocol have been more extensively described relative to optic neuropathies, specifically the thickness of the retinal nerve fiber layer, the optic cup volume, and the optic disc area. In this study, our goal was to further investigate all of the measures of this optic nerve head parameter and how they are related to elevated intracranial pressure in a cohort of patients with craniosynostosis at the time of their initial vault surgery, with the goal of strengthening the case for the use of OCT as a more sensitive and specific surrogate for identifying elevated ICP in an easy and non-invasive manner. Excluding those OCT scans with quality below 50, we found that increasing intracranial pressure was significantly correlated to decreasing optic disc cup volume, and that the group with intracranial pressure above 15 millimeters of mercury had significantly thicker max quartile and max octant RNFL, as well as smaller cup volume relative to those with ICP under 15 millimeters of mercury. We found a particularly strong relationship for patients with single suture craniosynostosis, with increased ICP not only correlated to decreasing cut volume, but also to increasing optic nerve disc area and increasing thickness of all three measurements of RNFL. Additionally, in the single suture cohort, the group with ICP above 15 millimeters of mercury had significantly lower cut volume, significantly larger disc area, and significant increases in the thickness of their three measurements of RNFL relative to those below 15 millimeters of mercury. While this relationship did not exist for the multi-suture cohort. So, looking at the optic nerve head parameters for non-invasive optical coherence tomography, increased ICP is significantly correlated with decreased optic nerve head cut volume. In single suture craniosynostosis, increased ICP is also significantly correlated with the increased optic nerve head disc area and increases in the retinal nerve fiber layer thickness. This further supports the use of OCT as a non-invasive indicator of the presence of increased ICP in patients with craniosynostosis. Thank you to our research fellow, Chris, to our recent craniofacial fellow, Laura, as well as to Drs. Taylor and Swanson. These are our references.
Okay, those were all excellent presentations. I'd like to now open it up to any questions from the audience. I'll be monitoring the chat room. While we're waiting for those questions to come in, I'd like to ask Jessica in the first paper, you showed the gender disparity in income. Did you match that for actual hours worked? Because many of the studies that look at disparity in incomes, when you break it down into the actual number of hours worked and the environment in which it worked, the disparity tends to be diminished somewhat. So did you, like, let's say somebody did an Allergan lecture for 1 hour. Did you see a difference in the pay that Allergan would pay a woman versus a man?
Thanks, Dr. Baker. I'm actually answering.
Oh, I'm sorry.
No problem. No problem. I'm here because Jessica's on call. To answer your question, no, that we couldn't find any information on hours worked, or the other thing was experience level over the years. That was another major limitation that might play into that. Unfortunately, we couldn't find that data because our searches were so informal. We agree that that definitely could be contributing to some of the data that we find and may increase or decrease disparities. It's hard to say which way that would affect the data that we were able to find, but unfortunately, we couldn't pull that information.
Right. So you actually preempted my second question, which was basing it on academic rank. You know, somebody who's a chairman might charge somebody who's in a community. But, you know, you should follow up on this, because if indeed disparities in payment occur for similar hours and similar academic rank, that might be something that the society should take into consideration and, you know, look at when we, you know, set criteria for private industry to engage our members. As a segue, I'd like to now ask Farah a question. You know, I thought it was a very good study and it made sense. The one thing that kind of jumped out at me was that the women thought sexism was the barrier to academic advancement. And I was wondering if you were able to break that down either by geographic region or whether it was a true academic system versus maybe a healthcare system versus private practice, and just the kind of hierarchy within hospital administration.
Yeah, that's a great question. So not based on our current results, that's definitely something we hope to do with our future study. The majority of the respondents were in private practice, but we weren't able to go back and look at that specifically within those that answered that sexism was a barrier to advancement.
Okay. And then Pooja, I thought your article was very interesting, looking at social media. And it makes sense that, you know, plastic surgeons, you know, Jesse Taylor puts 5 fast facts. I always make sure I like it for him. You know, he's a friend of mine. But what about non-medical people? Do you look at the general public and try to break down the demographic on who might be viewing plastic surgery literature on social media?
Thank you so much for the question. That's actually a really great point.
So we saw that most of the people actually engaging on Instagram with the plastic surgery journal content were plastic surgeons, academic programs, or plastic surgery affiliated clinics. However, we did not specifically analyze the non-plastic surgery affiliated population, but that's a great point to do for future analysis, just to understand who in the lay public is accessing these articles that are actually very high level in terms of their scientific content. And it would be very interesting to see if they're actually patients or just people from the lay public. Plastic surgery is a very commonly searched term, especially on these social media websites. So that is a great point for future studies.
Okay, well, I just realized my chat wasn't auto-populating and I pulled it up. So we've got 6 questions here. I'm going to start with one. Mr. Othman, do you have any suggestions to address the gender disparity in payments?
So thank you for that question. And that's obviously very important. I think this has been really identified over the past decade or so, and there's a lot of improvements that have been made, but I think the number one thing is transparency. We all know about gender disparities, but we need to bring light where these gender disparities are occurring, and the fact that even in industry payments they're occurring allows us to address that. Number 2, we need to identify in what ways there are barriers to women in kind of achieving equality in these areas. So in our study and in our lit review, we found that previous studies found that there's different lifestyle priorities for men and women, and mentorship, a lack of mentorship for women in surgery and plastic surgery specifically. So if we can address that and kind of accommodate to women, such as another thing that comes up is maternity leave as one example. Sometimes women really struggle with maternity leave. And when women have higher familial obligations, it can make it harder for them to be consultants or speakers and take on kind of the travel that's necessary to fulfill their industry obligations. So identifying these barriers and then practically laying out a plan to kind of help address these differences and what obstacles women may have in achieving equality are all potential solutions in getting us kind of on the right way to achieving equality.
Okay. Farah, the next 2 questions are for you. The first is, how did you word your questions about leadership and advancement?
So first we asked respondents whether they occupied leadership or administrative positions, and if not, whether they desire these roles. And then we asked about specific barriers to advancement.
Okay.
Yeah.
And then the next question is, only 57 of 360 respondents came from women. How can you explain the low response rate? Was the survey distributed in a gender neutral way?
So yeah, the low response rate is a direct reflection of the current gender disparities practicing plastic surgeons, with only 18% being female plastic surgeons. I think it comes out to 16% of our responses came from females. So I think that's just a direct reflection of the current gender breakdown of plastic surgeons.
Okay, you're up again, Farah. Do you think the differences in expressed interest in leadership positions reflect the barriers women face, or do they reflect differences in inherent interest in pursuing leadership roles?
So that's a great question, and that was kind of what spurred us to do this study in the first place. Our results right now show that there definitely is a distinct difference in the barriers that women and men face. Whether or not these barriers were the reason for seeking less leadership positions, we can't really say from the results we have so far, but we hope to specifically answer this with our, larger scale study.
Okay, great, thank you. Duncan, over to you. Dr. Lilikos from Mass General asks, optic disc paper is awesome. How still would an unanesthetized child need to be to get this study?
Duncan is actually not here to answer questions. I'm not quite sure if somebody else on the paper is here as a stand-in.
Okay, well, that would be really interesting if we could get follow-up. I actually really, really like that paper and think it's a really interesting way to monitor intracranial pressure with minimally invasive but highly sensitive and specific data when you have syndromic kids that potentially need, secondary frontal orbital surgery. So please pass along my congratulations to Duncan and the team for a great paper. And maybe if you see him, Liza, you could just have him answer that and maybe send it to the Northeastern if they can put answers to questions on afterwards.
That's a great idea. I definitely will.
Next question for the OCT. Okay, it's another Duncan question. Stan or Brian, if you can record these questions in the chat room and maybe send them to Duncan and then he can respond to them for the group.
Steve, that was our plan actually for all the questions. We're keeping records of them. So we'll be getting everything answered, even if it's not answered live. So thank you.
Okay. It looks like we're going back to the gender disparity paper again. Were there differences in the non-propensity matched cohort of respondents for the gender differences paper? How were they different from the matched groups?
So we didn't specifically run that analysis. That's something we can definitely go back and do.
Okay. Paige, the little MedStar Georgetown suit. You know I got to call on you. I thought that was an excellent study. You made it sound like the government has dropped regional licensure for telehealth, and I was still under the impression that I needed to be licensed in a state in which I'm doing telehealth care. Did the government reduce that barrier? Am I allowed to do a consultation via telehealth in Nebraska, or is that still a requirement?
Thank you for the question, Dr. Baker. My understanding is that those regulations are basically guided by state specifically. So it depends on the state that you're practicing in, is my understanding.
Yeah, I mean, I would say that, you know, just from a personal experience, and again, I work at MedStar where Paige is a research fellow, but, you know, I'm older, a little slower to adopt the technology, but I absolutely love it. You know, many of my aesthetic patients come from a distance, and I like to see them at least twice before surgery so I can bring them in once in person, do the Vectra, do imaging, you know, help get an assessment of what their goals are. But I always like to see them once again, just to do a Q&A, make sure all their questions are understood. And the telehealth is so enabling to see patients that live in West Virginia or Charlottesville or North Carolina. And then it just kind of decreases the burden of, you know, providing good care. And additionally, follow-up is so much easier for people, you know, in Washington, DC, you don't even have to live in another state. You could live 11 miles away and it could be a 90-minute commute depending on the time of the day. So for post-op wound care questions, I think it's really something good. And I hope that the government continues to keep the regulations intact so that we can use it as easily as we have. Does anybody else have any questions? That's kind of, I've ran my list of prepared questions from previewing your talks, and I think I've caught up on all the chat questions. And if there are no talks, again, I'd like to, you guys, just outstanding talks. And again, you know, Brian, PRRI, Suhail, you know, congratulations on being able to pull together such an outstanding educational opportunity for all of us. And hopefully we can all see each other again in person in Philadelphia next year.
Well, thanks, Steve. Thanks, Lisa. Thank you again to all the moderators. This has been absolutely wonderful. I'm going to pass it over to Brian.
Thank you so much, Steve. Thanks for the kind words. And thank you, Lisa and Steve, for participating also this morning. And thank you again to all of our moderators, all of our presenters. We really appreciate it. We pulled off day one, and I really couldn't be more proud or grateful for everything that went into this and all the participation we have. We've kind of averaged 120 people the entire time, which I think is actually even, you know, a little higher than it would have been live, which makes some sense. But it's nice that everyone has been present. So you may have noticed that there's been some slides here and there this morning indicating that the meeting was generously sponsored by several industry supporters. While we didn't charge anything for the meeting this year, we were fortunate enough to have industry support, which is going to greatly help our society in many ways, particularly considering the loss of income, you know, that comes along with a virtual meeting and cancellation of a great deal of events we had to do this year, given the environment. So if you haven't had an opportunity to visit the virtual marketplace, it's pretty cool. And I really encourage you guys to do so, please. Just you log into the virtual marketplace on the website, similar to how you got here, and you just visit live with members of our partner companies. Look forward to seeing hopefully most, if not all of you tomorrow. We have another outstanding session. I'm going to hand it over to Suhail shortly and then Dr. Mackay to present the Resident Award competition. And just once again, thank you to everyone who's been here this morning and everyone that went into making this a success.
Thank you, Brian. And again, thanks to everyone for sticking it out this long. I understand sitting in front of a screen can be a challenge, but it has been absolutely wonderful to have this level of engagement. I wanted to add one additional thing, which is in addition to the virtual marketplace, which is so critical to showing our industry sponsors how important they are to our society. We also want to draw your attention to the other abstracts that unfortunately we couldn't, just from time constraints, couldn't actually display. But there are 52 absolutely wonderful abstracts that are present in a virtual session. Every member and every participant in this meeting has the ability to go in and actually rate and score those abstracts, and there will be an award for the best abstract in that virtual session. Again, these are abstracts of the kind of quality that would have been at any other Northeastern meeting, a podium presentation, but just because of time constraints, we couldn't display. Again, we hope to see you here again tomorrow morning at 8 o'clock for the remaining sessions of the Northeastern. But before we bid adieu, I'd like to turn it over to Dr. Mackay, past president of the society, who has the honor of presenting the winners of this morning's residence competition.
Thanks, Suhail. And congratulations, Brian. I've known you for ages on the board. I'm delighted that you're president and you fully deserve the second term. I don't think it's punishment.
Thank you, Don.
And Suhail, great job in putting the program together. Stan, another great job. The kind of quality we expect from you guys. Thank you. You know, so I had a casual shirt on, and then I saw all you guys in your jackets and ties. So I went and put a tie on. I'm not going to stand up. And then I saw Bucky come on in the casual shirt, so it would have been okay. But anyway, to all the folks that presented today, you guys did an outstanding job. It's terrific to see the quality of the work that is presented at the Northeastern. I've got to say that there are two societies that I thoroughly enjoy. One is the association and the other is the Northeastern, and they're incredibly good value. Well, you've produced great virtual value. The folks putting together the work and the quality of the presentations was awesome. It's great to see our specialty continues to do well with innovation and some great thinking. So enough. The second place for the resident competition, the second prize goes to Kevin Chen and Turning Back the Clock with Facelift Surgery, Artificial Intelligence Recognition. So congratulations, Kevin. I'm assured your check is in the mail. Then the first place goes to the Penn Group, Viren Patel, Prospective Real Work Assessment of the Abdominal Hernia queue. Congratulations, Viren and the Penn Group. Another great contribution to our specialty. Brian, Suhail, thank you. This was an honor. I really appreciate it. Thank you both.
Thank you, Don.
Thank you, Don, for doing that. Congratulations to both groups who won an award and to those who presented. So I suppose this concludes our first day. I've given thanks over and over. I'll do it one last time. And I hope to see most, if not all of you tomorrow. And please don't forget to visit the virtual marketplace for our industry sponsors and do review the virtual abstracts. Suhail, I just want to echo what he had to say. They were just as good as the ones on the podium. It was a very difficult decision to decide which ones would be shown live and which ones would be virtual. And it literally just came down to time constraints as to why those papers weren't presented live this morning. So I wish you all a wonderful day and evening, and I look forward to seeing you tomorrow morning.